Sir, good morning, sir. Vijay Raghavan, sir.
Good morning.
Sir.
Hello.
Prasanna, sir.
தெரியும்.
PG class எடுத்திருக்கீங்க சார். எனக்கு பாண்டிச்சேரியில MGMல இருக்கும்போது.
மகாத்மா காந்தியா? வெரி குட்.
சார் கேட்க மாட்டீங்க.
இப்ப கேக்குதா? ஹலோ.
சார் கேக்குதுங்க சார். இப்ப சொல்லுங்க சார்.
அதான் வந்து ஞாபகம் இருக்குடா. நாங்க
2017ல
ஞாபகம் இருக்கு.
உங்களோட கைடன்ஸ்னால ஃபர்ஸ்ட் மார்க் ஸ்கோர் பண்ணிட்டேன் சார் நான்.
ஐயோ பெரியல்டா.
ஒரு क्वेश्चन கேட்டிங்க சார். எனக்கு ஞாபகம் இருக்கு. ஆல்பினிசம்ல வந்து கிராஸ் ஆகுமா அப்படின்னு ஏதோ ஒன்னு கேட்டிங்க. அத நான் கரெக்ட்டா
கயாஸ்மால
நேம்
நான் சொத்து எழுதி கொடுத்துறேன்டா அப்படின்னு.
You can change the name.
அந்த क्वेश्चन எனக்கு ஞாபகம் இருக்கு சார்.
சரி
Zoom account laptop store.
Nice to meet you sir. இன்னைக்கு
But you can change. இதுல போடினா you can change.
இப்ப கோயம்புத்தூர்ல இருக்கியா? இங்க தானா?
சார் அங்க 2 years fellowship சத்யன் சார் கிட்ட பண்ணேன் சார். அப்புறம் இப்ப வந்து 1 year ஆச்சுங்க சார். 17ல முடிச்சேன். இப்ப லாஸ்ட் இயர் நவம்பர்ல இங்க வந்தேன். கரெக்ட்டா 1 year ஆச்சுங்க சார். இங்க இப்ப குளோகோமா பிராக்டிஸ் குளோகோமா அண்ட் ஐஓஎல் பண்ணிட்டு இருக்கேன் சார்.
வெரி குட் வெரி குட்.
உங்க அந்த லாஸ்ட் மினிட் இதுல வந்து நிறைய லேர்ன் பண்ணுவோம் சார் அந்த டைம்ல.
ஞாபகம் இருக்குடா. நல்லா
பயங்கர இன்ஃபர்மேட்டிவா இன்னைக்கும் நிறைய லேர்ன் பண்றதுக்காக தான் சார் இருக்கேன்.
ஓகே
சார் ஸ்டார்ட் பண்ணலாமா சார்?
பண்ணலாம் சார். ஒன்றும் ப்ராப்ளம்.
ரெடி சார்.
One second, give me a second. I think Vijay one top line and tell. Okay, but when sir, you can initial, so we'll start, sir.
Yes, sir.
Good morning. Yeah, good morning, one and all. This is Oculofest 2020 webinar. This was basically meant for all the undergraduates. I hope this session will be of real use for all you people there. Welcome to all my students and students from other colleges also, people who are participating here. At the outset, I would like to thank all the speakers for having volunteered to join us for this event. It's been a great honor to introduce the first speaker, my guru, my teacher par excellence, Captain Dr. Vijay Raghavan sir. He's going live from Coimbatore. Thank you so much for having consented, sir, to really address the undergraduate students on this day. You've been a great enthusiast for the Oculofest event right through the years, and you've been a part of this event for so many other years also. So thank you once again for participating in this year.
Okay,
thank you, sir. Thank you so much for.
Thank you.
Now we like first speaker, Captain Dr. Vijay Raghavan on screen, please. Live. Thank you, sir. Sir is the retired professor of ophthalmology. He was my teacher at the Regional Institute of Ophthalmology. So he was the academic director of Arastan Eye Hospital. He's a visiting professor for various postgraduate eye institutes like Arvind, esteemed institutions like Arvind, Sankara Eye Institute, and LVP also. LV Prasad Eye Institute, one of the premier institutes in India. So as you know, all these students are people who are aiming to pursue ophthalmology, who would like to get encouraged and be inspired by various teachers now on this platform. As you all know, one of the premier institutions in the country for ophthalmology will be AIMS Delhi, followed by LV Prasad Eye Institute at Hyderabad, then followed by Shankaranath at Chennai, then Arvind Eye Hospital, and Shankara Eye Institute in Tamil Nadu. So these are the various institutions, and sir has been a part of this thing. He was captain of the army. He served in the Indian Army for 5 years, and he was 28 years. He's been a teacher at various government medical colleges, and I'm very proud to say I am his student, and I follow his footsteps. A very avid learner as well as a teacher, who was very friendly towards all the students as well as the postgraduates, and I'll be very happy, and I'm very honored to even say that he still calls me Partha. So one of the very few teachers who calls his students Vada Poda. So I'm really proud to be called Vada Boda by him. So thank you, sir. Thank you, sir, for joining us today. Thank you. You can start your program, sir.
Okay, thank you.
Sir, good morning, sir.
Good morning,
Good morning, Vijay.
Good morning, sir. Sir, this is a wonderful program. Thank you for organizing, sir. The participants sir, enga ponalum kalakkikitte dhaan sir irupparu.
Thank you, Vijay. Thanks for joining us. Thank you, Vijay. Looking very bright and smart on Sunday, Vijay.
Sir. No curry, sir, today. Sir, thank you, sir.
Thank Vijay, you. Good morning. Vijay, good morning.
Good morning, sir. Sir, unga aasirvadathoda aarambo sir iniki.
Okay, thank you, da.
Okay, sir. Thank you.
Good morning, Vijay, sir. Morning, sir.
Good morning, Prasanna. How are you?
நல்லா இருக்கேன் sir. நல்லா இருக்கேன் sir.
Oh, super. Good, Prasanna. Thank you.
Sir,
okay, I'll start.
Yes, sir.
Good morning. I thank Dr. Partha for having invited me for this great occasion. I've been attending Oculofest for the past 5 or 6 years. I find it very useful for me. For me also, I learned a lot from the Oculofest. My topic today is ocular side effects of systemic drugs. We know there are so many drugs we are taking orally or anyway, systemically. They can have some, or they can induce some changes in the eye, or the problems, symptomatic problems in the eye, you should know. So the patient comes to us, some complaints. Not only when you ask for a past history and all, you are supposed to look for or ask for the history of drugs intake, which can give us a lot of clues regarding the problem in the patient. The common complaints, the patient normally come to us in ophthalmology department or OP outpatient department. Of course, diminished vision, and they will tell some color vision problems. They will sometimes tell, I can't see red, I can't see green and all, or they will tell, I'm seeing yellow vision or a blue color vision, or sometimes I see double visions. And sometimes they will tell you, seeing as if I'm through a mist. And another complaint is not seeing the central part. Suppose he is seeing the person's face, he cannot see the nose and all. That's called the central part, cannot be seen. Sometimes they will tell what flickering lights. You might have heard about migraine also normally. Migraine patients can have scintillating scotomas. Like that, after taking drugs, the patient may complain of flickering lights. Then sometimes like in the glaucoma, you must have heard about an MBBS level, that is seeing rainbow colored halos. Same thing, after drugs also, the patient can give a complaint of seeing rainbow colored halos. I will take one by one here. Always, that's why I'm stressing the importance. Whenever you see complaint in the patient, if you're not able to come to a conclusion at all, never forget to ask for the history of having taken some drugs. So this will definitely click the diagnosis. See, now here you see the patient comes to us, he's seeing everything, sir, I'm seeing as yellow. That's called xanthopsia. Xanthopsia means yellow vision. Those undergraduate students who are going up here for postgraduate NEET examinations, this is a common question. Yellow vision occurs after which drug? They can ask like these questions. You're supposed to know digoxin. Digoxin can cause yellow vision. The reason here is because of mild changes that are taking place in the lens, like cataract changes, which can become yellow. So naturally, patient can see everything as yellow. So xanthopsia or yellow vision is caused by digoxin. Undergraduates, please note down so that in future, when you write a PG entrance examination, it's a common question. Similarly, blue vision, patients see everything blue. That commonly, we are using, that means sildenafil drugs. What happens to these sildenafil drugs? It's a phosphodiesterase 5 and 6 enzyme, that is inhibitors. Diesterase 5 for other problems, whereas diesterase 6, it is actually present in rods. So when it's inhibited, rods are highly become sensitive. So when the rods are sensitive, that means what? It's a night color vision. Night vision is better. So naturally, night we are supposed to see blue better always. That's why the patient is getting an experience of a blue vision after having taken this drug, sildenafil. But this will not persist for so many hours, maybe 2 or 3 hours. But the long-term effects you are supposed to know. Some of the changes may affect, they're not yet published, may produce some changes, permanent changes in the rods, means you will have a problem. Other drugs like double vision, patients having taken some drugs and he starts telling that I'm seeing everything double. The reason here is, one of the commonest reason given is, we can have tendon of the muscles, extraocular muscle tendons can get inflamed. It's called tendinitis. the most commonly taken drugs, never forget this, commonly taken drugs like fluoroquinolones. For example, ciprofloxacin. Ciprofloxacin drug can produce tendinitis. Patient can get double vision. Other drugs you can have, so many drugs are given. But commonly, the common drug which you are using is ciprofloxacin, that type of fluoroquinolones. They can produce double vision in the patient. See, now other things, see, patient comes to you, sir, I'm having a red discharge. The tear fluids are becoming red. Everyone knows that. Antituberculous drugs. Rifampicin mixed with the ocular, we got internal fluids are there. It mixes with fluids of the body fluids. So naturally, the tear fluid also getting stained. When they come out, becomes a red color. And you must advise the patient not to bother about this. And one more, they will, after consuming rifampicin, they will have red or orange colored urine. They will pass. So naturally, that also is harmless. Never forget, you must explain the patient. Once you have prescribed rifampicin, you must tell him your urine may become colored, or sometimes you may get red colored tears. These are not problems. It's all concerned with only the drug itself. It's not a major problem for them. Once you stop, it may disappear. Here the problem is what? Suppose a person is wearing contact lenses, like soft contact lenses. When you prescribe rifampicin, we ask this question also, because the soft contact lens, because the tear fluid becomes going to red in color, they can stain the contact lens. That's why better to avoid soft contact lenses in these patients who are taking rifampicin. Another, I told you, misty vision. That is, patient sees everything like as if through a mist. That's a classical drug, more commonly taken by females after 40 years and all, for the bone strength. Osteoporosis. Bisphosphonate. Bisphosphonate is a classical drug normally prescribed for females and all those who are having bone problems, and they are liable to get what is called this misty vision. The reason here is because they may develop a possibility of inflammation inside the eye, that is called iris. Iritis may be the reason for your misty or a blurred vision. The classical drug is bisphosphonate. Other drugs are there which we are not normally using. That's a problem. Amiodarone, of course, maybe. Amiodarone maybe. But tamoxifen very rarely we use. Now, another drug, topiramate, that is for anticonvulsant and all. This drug, they can produce what is called above the ciliary body, above the choroid. They will have effusions. So naturally, they can push the ciliary body forwards, and the anterior chamber getting closed, the angle getting closed. They will have a raised intraocular pressure that can result in acute closed angle glaucoma patients. See, now they can see halos. Everyone knows angle closure glaucoma patients can have or can see halos around lights. Similarly, he's having now raised intraocular pressure. He can see halos around lights. Never forget, suppose maybe a case of glaucoma, agreed, but never forget to ask, are you taking topiramate drugs? That itself can give us a clinching diagnosis. So topiramate, I told you. See, now sometimes what happens, the patient having taken some drugs, they will see a flickering lights like this. Similar to migraine, they are called scintillating scotomas. Scintillating scotomas or fortification spectra. This is the classical premonitory signs of migraine. Patient can experience in aura. Similar problems here also the patient can have. Never forget. Of course, normally, adimadram and all, these are all not drugs we are not consuming. But never forget, you must ask, some of them may be taking these drugs, adimadram containing drugs, or never, again, one more thing I'll tell you, clomiphene, commonly that is females, they might have consumed clomiphene. After 2 or 3 days, what happens now? They will give a complaint of this scintillating scotomas. The reason is they are seeing some image, it's getting persisted in their brain. It's called after images. A persistence of images kept on getting the same image. It can give us this type of scintillating scotomas. So when you have a scintillating scotoma patient, not only migraine, you must ask for, if it's a lady, you must ask for the history of having taken clomiphene, citrate. See, now sometimes the patient cannot see the central part of the face, central part and all cannot be seen. These are all what? The problem may be in the retina, macula, or maybe in the optic nerve. That's the reason patient can have it's called central scotomas. I'll tell you so many drugs are there, but I'll tell you. Now I'll tell individual part of the eye. When you find some problem in the individual part of the eye, you have to ask for some leading questions. What drug are you taking? This I'll tell you one example here. See, now subconjugal hemorrhage. See the subconjugal hemorrhage is here. This subconjugal hemorrhage is here. When you see a person of subclinical hemorrhage, of course, trauma, so many problems are there, normal problems. Subclinical hemorrhage automatically gets subsided after 2 or 3 weeks. But you must ask for the history of aspirin intake, or at least clopidogrel or coumarin. That means a blood anticoagulants you are supposed to ask. So the patient can have a bleeding tendency and they can have a subclinical hemorrhage. So when you have subclinical hemorrhage case, you must ask for the history of these drugs intake. Next, I'll tell you. See now, cornea. Can you see here cornea, some lines and all? These are some of the lines. Can you see a line here? These are all the lines that's called vortex keratopathy. Vortex keratopathy or cornea verticillata. My dear students, MBBS students, this is one of the commonest questions for NEET exams. For postgraduate entry, that is entrance test. See what are the drugs which can produce a change like this? See, the vision may not be affected much, but the drugs can produce what? Never forget chloroquine. Chloroquine, apart from producing problems in the lens and the retina, they can produce problem in the cornea also. It's called cornea verticillata. Hydroxychloroquine, this group can produce. And of course, another drug I told you, amiodarone. And one more drug is there, atavacone. Atavacone is, you know that, it is given for antitoxoplasma. These 3 drugs, you must know, the patient can develop something else, whorls or a lines in the cornea, in the lower part of cornea. These are all called vortex keratopathy. This is what a classical NEET exam questions for you. Now next I'll tell you here. Chlorpromazine. Never forget chlorpromazine. This antipsychotic drugs. They can produce many problems in the eye, not only the cornea, in the lens, in the retina, everywhere they can produce changes. You must always ask for that. Chlorpromazine can produce in the cornea so much of changes in something like that, small crystal-like things in the stroma. But you should know that the doses greater than 500 milligram per day for prolonged periods, they can produce a problem in the cornea. But these are all irreversible. Never forget that. Now, next go to iris area, uveitis. Is also never forget. Please remember, our student, PG, UG students know this. Rifabutin. Rifabutin commonly given for tuberculosis patients and all, with other drugs in combination, immunocompetent patients and all, even for atypical mycobacteria. This drug, another drug, bisphosphonate, I told you already. Cidofovir, antiviral drug. Cidofovir, antiviral drug can produce uveitis. That means how? You can see hypopyon in the patient. You can see hypopyon. And irregular pupil. All these things you can see. That means he is having uveitis. When you see some, you are not able to come to a conclusion of any etiology. In the past history, at least you must ask, or even present. That means what? Are you taking drugs? Most important aspect is, are you taking drugs like rifabutin, bisphosphonate, or cidofovir? These are the drugs which can produce uveitis. Now the cataract. Just by seeing the cataract, you can tell what problem the patient might have consumed. The drugs, as far as drugs is concerned. These are all, again, I repeat, I'm telling you now, these are all MCQs for NEET. Anterior capsular. See, the lens has got capsule, cortex, nucleus, everything is there. So anterior capsular cataract is there. You must always ask for chlorpromazine drug. Chlorpromazine can produce anterior capsular cataract. Then anterior subcapsular, under the capsule, in the anterior part of the cortical areas, under the capsule, anterior subcapsular. Your answer has to be anticholinesterase, amiodarone. Amiodarone and anticholinesterases like physostigmine, neostigmine. These drugs can produce anterior subcapsular opacities. And the posterior subcapsular, under the posterior cortical areas or under the capsule, post subcapsular. Never forget these 2 things, steroids and chloroquine. Steroids and chloroquine can produce posterior subcapsular cortical cataracts. So classical, again I'm repeating now, anterior capsular chlorpromazine, anterior subcapsular amiodarone anticholinesterases, posterior subcapsular chloroquine and steroid. These are the common things that by noting down the area of location of the opacity in the lens, we can tell you this is the problem in this drug would have patient would have consumed. Now the drugs affecting the retina. Again, I'm coming to chloroquine. A chloroquine can produce, you can see a change here. This optic disc, this below you can see some changes. This is called a bullseye maculopathy. Bullseye maculopathy. Never forget that. Bullseye. bullseye maculopathy that can be produced by chloroquine or hydroxychloroquine, but hydroxychloroquine is somewhat less toxic compared to chloroquine. See, now the patient has got this problem. That means what? You would have consumed more than 300 grams of cumulative dose. The cumulative dose of chloroquine would have crossed 300 grams. Then the fellow will definitely have these problems. That means what? As an ophthalmologist or even normal physician, whenever you give chloroquine, when the cumulative dose, that means total dose of consumption, if it is increasing more than 100 grams, try to have his eye checkups. So once you have eye checkup, you can easily find out the problems. If you start the drug, this problem of bullseye maculopathy will never occur. That means what? Once this bullseye maculopathy has occurred means it's irreversible. That means you can arrest the problem before the problem bullseye maculopathy starts. That means when the patient dose is crossing over 100 grams cumulative, try to get eyes checked. That's all. Ophthalmology will do his own. There is examinations, techniques and all. There are so many investigations available. Phenothiazine, again, they can produce classical salt and pepper fundus. Salt and pepper fundus can occur after taking some phenothiazines like thioridazine. Never forget, the same thing can be affected. This salt and pepper fundus can also occur in a syphilis case. Of course, syphilis, you're not seeing patients, but syphilis patient can have salt and pepper fundus. These are all, again, stressing the importance of MCQ for NEET examinations. Chlorpromazine, again, see, they can produce atrophy, diffuse atrophic changes in the choroid, pigment epithelium. Everywhere you can have a atrophic change. That's what I told you. Chloroquine can produce changes so many parts of the eye. Sorry, chlorpromazine as well as chloroquine. Drug-induced maculopathies. Now you should know this tamoxifen, which is given for breast cancers and all. These patients, suppose they come to you after having consumed tamoxifen, he's telling, I'm not able to see the center part of the face. Better be careful. You might have developed a problem in the macula. That is, macula means the central part of the retina, which is responsible for our central vision. That may be affected. Nowadays, they are giving interferon alpha and all. They also can produce retinopathies, like they can have hemorrhage, they can have, just like hypertensive retinopathy, like pictures. They can have hemorrhage, they can have X-rays, they can have corneal spots. All the problems can occur once they have taken interferon alpha. Interferon alpha 2 and all, 2B and all, given for ocular surface neoplasms. They can give topical drugs as well as injections. That is why interferon alpha 2B commonly used for malignancy like carcinoma in situ. You have to be very careful, these patients. Nicotinic acid, they can produce macular edema. Never forget that. Macular edema can occur with nicotinic acid intake. Everyone knows optic nerve problems. Ethambutol, isonic acid, there are so many antituberculous drugs. They can produce problem in the optic disc. Not only optic disc, problem here is whenever you see a patient of papilledema, that too in ladies, never forget, apart from other etiologies, you must always history of having consumed or taken this tetracycline group of drugs, or even vitamin A, steroids, anything can produce papilledema patients. We have got tamsulosin. Normally it's given for prostate enlargement patients, and even for females also they are giving nowadays for incontinence of urine. So tamsulosin is what now? It's an alpha-1 blocker. It's an alpha-1 blocker. What is there? How that problem is occurring? In the iris, dilator muscle has got alpha-1 receptors. When it is blocked, the dilator is not working. Only the sphincter is working. That means what? The sphincter is touching the iris, so become floppy. It is not equal. Inhibition is not there. So that actually it contracts. So naturally going for floppy. Why I'm telling them this floppy iris, when you see doing cataract surgery is difficult for a fellow, because it's very difficult to touch the iris. When you do the touching the iris, right, it will tear and come. That's a problem. Floppy iris syndrome patients, we have to be very careful. When you see, you must always, before admitting for cataract surgeries, you must always history of having taken tamsulosin. But the problem here is what? Even if you stop tamsulosin for 2 weeks, 3 weeks, nothing will happen. The patient still have this floppy iris. That's a problem for the patient. Cyclosporin, everyone know that. Thank you very much. I once again thank Pata for the kind invitation. Thank you very much.
So thank you, sir. It was a great oration, a beautiful lecture. So thank you so much, sir. I think all the undergraduates should really appreciate the excellent the slides that have been covered. And I think it's a great insight into all the various drugs that can be used in ophthalmology. I think it's a real privilege to have you as one of our speakers, sir. Thank you so much, sir. And I think for all the undergraduates, I think it's a real eye-opener for all the various drugs and its side effects in ophthalmology. And very commonly asked questions, even for the postgraduates, it will be very useful when we go into the Viva. Most of the drugs, and one of the drugs which have been into focus recently is the topiramate, anti-consumer medicine that have been used, where we have started seeing a lot of cases with the acute angle closure, with the people with the corneal edema. And so one of the causes for the halos, as undergrads, all of you will know, there are 3 types of halos. So one will be the lenticular halo and the corneal halo, and the one will be because of your mucopurulent conjunctivitis. So this is one of the causes for the halos here, is the corneal halo, because of the corneal edema and increase in intraocular pressure. Thank you, sir. It was real an eye-opening talk, and very privileged to have you as the very first speaker in this. Thank you. We're really indebted to you for all your excellent cooperation during various Oculofest that we've held so far. Thank you so much, sir. Thank you so much.
Thank you, ma. Thank you.
Thank you, sir. Thank you, sir. Next, I would like to go into the next speaker, Vijay Shanmugam, Professor Vijay Shanmugam. He's head of the department at Government Rajaji Hospital, Madurai. And at the outset, he's been the recipient of the Best Service in Medical Faculty Award twice in the year 2011 and 2014. He's been a guest speaker at various conferences and CMEs, person who has cleared his fellowship exam. I think even sir has cleared his fellowship FRCS. So clearing FRCS is not a lean task. It is a huge task. A very avid teacher, an excellent teacher per se, and a very skillful, excellent surgeon, very apt in all the various findings. He was really my, as you would say, I would not call it as a right hand, my real pillar of support when he was here with me in Trichy. It was a huge loss to all the undergraduates and the postgraduates here in Trichy, but again, a huge gain for all the Madurai students, for the Madurai undergraduates, and I hope most of them will be listening. And I can talk eloquently about Vijay for days together, but a very good friend of mine, an excellent teacher. And I think my sincere thing to all the postgraduates and all the undergraduates in Madurai is to make use of this guy. So here is a person who has to be approached. He has to be approached. People have to approach him to really involve him in all the classes. So he expects that kind of a thing of the students to walking up to him. And he's a person with oodles of talent and oodles of knowledge. So I hope
I'm having goosebumps, sir.
Thanks, Vijay. Not at all, Vijay. This is a part of this thing.
Teachers should not say so much about their students, sir.
Not at all, Vijay. We are honored to have you here as part of the program. Thank you. A benefit for all the students here of 2017 batch. Thank you, Vijay. On to you, Vijay.
Thank you, sir. Thank you. Sir, with VRV's blessings and your blessings, we will start this with all teachers. Welcome to all my teachers and my dear students from various colleges. I see a lot of colleges over here. Every time we are talking about ophthalmology, we are talking about something. This time, sir has picked up a subject where side effects of ocular medications, very rare. I have not seen till now. We just add it in the, so we thought we'll do something also different. So, guys, can you hear? Everybody can hear, right?
Sir, it's audible, sir. It's audible.
Thank you, President.
Yes, sir.
See, can you see one person over here? One smiling face over here. Does anybody know who is this? Anyway, now we do not have time. Sir has given me only 20 minutes. So we'll try to compress everything in 20 minutes. So I don't think I can get your responses and then we can go in two-way. If it is going to be live, it cannot be two-way because now we have running constraint because of this time constraint. Let me just put the questions. Think about the answers in your head. And then the next slide, I will tell you what it is. Okay. This is one person who was in Hitler's army. He was a doctor called Joseph Mendel. He was conducting a lot of experiments on human patients. Maybe he called it for the development of science. He is called the doctor of death or the angel of death. You know what did he do? He injected drugs into the live patients or live children's eyes to see if they change his color or not. And then he removed those eyes and then he just put it on the wall, like a wall hanging. There are a number of patients who have lost their eyes because of this guy. Number of patients who have lost their life because of him. He's done a lot of experiments, and to prove those experiments, he used to autopsy them also. He used to cut up patients without giving anesthesia. Okay, this occurred way back in 1942. You must be wondering, why are you talking about something which has occurred 20 or 30 years or 50 years or 70 years back? In 2016, a professor from the US, who is a genetic professor, he could not do a study in the US, so he picked up his subjects in China. He went across the globe, picked up his subjects in China, and conducted experiments on them. Where in 2016, mind you, 4 years back, he cut open the children's eyes on the lens of the children to see if the germ cells mutate and congenital cataract goes back or reverts back. He produced such a hue and cry in this world. Why am I telling you all this? These are all concerned with today's topics. This is the ethics and more medico-legal aspects in ophthalmology. Let me introduce myself. I'm the head of Department of Ophthalmology in Madurai Medical College. I'm a very proud student of the previous speaker. I'm Dr. U. Vijay Shanmugam. And all what Parthiban sir said was false, but you should be with me to see what I'm. Okay, what are the learning objectives today?
People can really appreciate what you're talking, Jay.
At the end of, thank you, sir. At the end of this session, you should see basic principles of bioethics. Why MBBS level I should know bioethics? Discuss the ethical dilemmas. Here I will give you a few dilemmas. Since for the want of time, I'll give you a few ophthalmic dilemmas. You think about what their answer can be, and then I will discuss, or one way I will tell you what it is. You can see whether you're correct or not, and describe the medico-legal aspects pertaining to ophthalmology. Okay, here, whatever in 20 minutes I'm going to talk, if you take content work 2 minutes is all that I want. So please pay some attention. I'm talking about ethics. When a senior most professor who is 60 is going to go 70 years old, who has been teaching for the past 4 or 5 decades, I can see students writing on the screen. Do you think when you're presenting, would you like somebody writing on your screen and distracting all the other fellow students? No, you wouldn't. So this is one of the basic. It is not law. It is not that you shouldn't do. Nobody is going to put you in jail for it. But see, one person is presenting, he's put his heart out. But since you are doing this is what I call ethics. This is what is ethics. Nobody will teach you. You have to imbibe by seeing other people. So what is this ethics? It is a principle of right or wrong, good or bad judgment. There should be ethics. There is no law for ethics. There is no say, they're not going to put you for jail in this. But this is common morals. Morals means it is an individual. What is right for me, wrong is wrong for you. But what is ethics? Generalized. The society tells you that this is how you should be. If you are a doctor, you should be dressed well. You should be presented well. You should present well. You should be very, very cordial to your patients. This is what the society expects from you. This is what the moral values you got to inculcate. This is called ethics. All the definitions will be given in various textbooks, but these ethics should be imbibed. It should come into you. These are empathies which you should absorb. These are a set of rules of standard governing the conduct of a particular class of human action or profession. See, this profession, we have come into a so-called creamy layer and so-called noble profession. Everybody thinks that we should not earn at all. No, it is not that. We are earning, but only thing we earn with dignity and grace. That is what we are expecting. And as teachers, we have not been taught this, but now it has become a subject in the new curriculum. We have to teach you. We have to assess your skills in ethics also. So now I go to some basic principles of ethics. I'll give you certain case scenarios. 10 seconds, you think about it. What I want you to be the patient here, not the teacher here. Be the patient and see or try to feel what the patient feels. That will bring out the principle in you. See, here's an old gentleman here. He's picked up from a camp. He's very poor. As you can see, he's a very poor, low socioeconomic, elderly male here. He comes to our hospital, very common scenario. He comes to our hospital for disability certificate. On examination, you can see he's got a bilateral mature cataract. So I feel, as a physician, I feel that the government has told me that to give him a certificate because it is his right to claim the certificate. But to get a certificate, he has to warrant it. To merit it, if he gets a cataract surgery, he will lose his certificate, but he might get back vision. But the patient from himself, he thinks that if he does the surgery and if he gets back his vision, he will lose his disability, and then he will not get his small remuneration which he is used for eating for himself. He doesn't have a family. Do you think who is right now? There's ethical dilemma. The doctor is saying you have to get surgery. The patient is saying, no, I don't want surgery. Who do you think is right here? This is a real dilemma here. Who? Just think. This is one called autonomy. Okay? Autonomy means it is the decisions for the patient. It is his body, his right, his body, his right. He can take his decisions as he is alive. Once he is dead, it's okay. But if he is alive, he should make the right. He should be equipped to take the decision, and he should decide. Okay, you can't take a decision. If he says don't operate, you have no right to touch him. No operation at all. This autonomy, now I think you understood. It has a lot of subsets. What is this privacy and confidentiality? A lot of people have now, Western world, these doctors have got caught into problems because of this confidentiality cost. It is a privileged information which the patient gives you. Suppose the patient says HIV positive, you cannot go ahead and advertise to everyone that this guy is HIV positive. Be careful, HIV positive. Don't do this. No, you can't do that. It is a confidentiality the patient maintains. This you can keep it only to yourself. If you see a lot of law serials, you will find this class, a lot of that. Consent. Without the patient's consent, you cannot do anything. You have to, he walks into your clinic, it means he's giving you a consent that you can examine him. That is an implied consent. But if you are examining him, you have to get the consent. If you want to do a surgery for him, you have to give a consent. If you are going to do some medicine on him, you have to get his consent. Anything. If he doesn't agree for one thing, you have to give him alternative options for him to choose. Oral contraceptive, like you spread it on the table, it's up to him to choose. So this consent is very important. So autonomy, patient decides. It is his body, his rules. Okay. Now I give you, these are all the principles. There are 4 main principles. Okay, these are the cardinal pillars of ethics or bioethics. This will be asked as a short notes for you all in medicine, surgery, maybe in preclinical also. This is important. And 5% we have to allot for this, and 20 hours should be allotted for bioethics in undergraduate level. See, second case scenario. Here's a midwife or a small homemaker. She's a middle socioeconomic group. She's come to you. In your clinic, she's a known glaucoma patient. Okay. It is a known glaucoma patient. There are a lot of drugs for glaucoma. Okay. In your clinic, you have stuffed the drugs which you think your practice only lower level drugs you have stuffed. But this patient warrants a higher level like a latanoprost, very expensive drugs which she cannot. Somebody raised their hand. Okay. This is a very expensive drugs which she can't afford, but that is the best drug which is suitable for her type of glaucoma. Okay. And she's asthmatic. So suppose very cheap drugs like timolol is available, or any beta blockers are available. These are cheap. In your clinic, you stuff only these cheap drugs, and you say that I shouldn't give her latanoprost, thinking that it is very expensive, so I can give her timolol and send her off. Timolol does not work at this level, but even then you're giving. What is this principle here? What is the ethics here? You want to push one drug, but the benefit patient should receive is some other drug. So what is the principle here? It is the principle of beneficence. See, the provider must treat only for the benefit of the patient. Which is the best benefit the patient receives, only that should be given to the patient. No alternatives. Patient does not want that, it is different. But if this treatment warrants for this disease, then you treat only with that. If surgery is the best option for this disorder, surgery is must. For example, congenital glaucoma, you do gonioscopy or goniotomy. There you can't do a trabeculectomy. That means you decide which is the best benefit for the patient. Okay. Now I'll just run through because want of time. We can sit and talk for hours in this or maybe years in this. But see, this is a young girl, very common. You think that you are the one girl over here who's coming to see an ophthalmologist for spectacles. She is coming for a routine refraction. But then you are working in a corporate level who has got lasers, who have got advanced LASIK machines, you got advanced phaco's. So what you do is you give her an alternative saying that, why are you wearing glasses? You're looking so nice and so smart and so beautiful. I'll remove the glasses for you. All you have to do is undergo a surgery. Just one surgery. She says, no, I want glasses. That is enough. I'll go for surgery later. No, you have to go for surgery. And then why this guy is pushing is, previous month, this patient, this doctor has sat in a meeting where all his seniors have told him that if you don't show your results, you are chucked out of this hospital. So what will he do? His dilemma is he has to push for surgery. The patient's dilemma is, why should I have an invasive procedure when I have a simple alternative for it? Both are giving me a good result. Why should I go for a more invasive procedure? So what is the principle over here? It is non-maleficence. It means you should not hurt your patients. Don't push something which is invasive to the patient or which can cause a damage. The damage caused by spectacles is negligent, but if you have any complication during LASIK, the patient can lose vision. So this is a principle, very important principle is non-maleficence. So first is autonomy, second is beneficence, third is maleficence. Now I'll give you the fourth scenario, which are the fourth pillar. See, this is one case scenario. Just think about these case scenarios for 10 seconds, thinking that you are the patient, right? Here is a patient who is blind both eyes. He's a small farmer by occupation. He is blind. He cannot go to the farm because he's got both eyes corneal blindness. And now the hospital, you are sitting in a corporate hospital, you received a very young patient, an accident patient, accident victim donor, who because of his accident has lost one eye, who got smashed, but they want to donate the other eye. So one eye is very healthy. So you have registered with the eye bank saying that I'm going to put this eye to this elderly gentleman so that he can have some livelihood. But the hospital is saying, no, I'm going to receive the governor's son who has lost one eye, who has got a scar in that eye. I want you to put the only eye which is there for this patient. Thinking that the governor will give you a lot of donations. He is bringing you a lot of donations. Now your dilemma is, what am I going to do? Am I going to put it for the elderly patient who really warrants it, or one guy who is coming to you with all the money and wealth and influence, who has just wants a cosmetic correction in this side? This is the fourth. So you cannot discriminate someone on their caste, creed, color. Everything should be the same. This is justice. So 4 principles of bioethics are autonomy, beneficence, maleficence, and justice. Okay, this you should never forget. It should get into your head. These 4 things you take home is all that enough for me. What the credit goes to me if I'm going to drive all these 4 principles into your head. I'll just give you one more scenario. See, why I'm giving you this scenario is, other than the principles, is because now the current education system or the curriculum wants to drive this principle into your head, into the head of MBBS students, who have to develop this right from the first day they join medicine. See, for example, there is a retinal consultant who comes to a corporate hospital only once a month. Okay, so he has admitted one patient with retinal detachment surgery, and he asks the staff nurse, or he asks his resident to prepare the patient for surgery. He's going to take up the surgery next day. But you know what the resident does? As usual, you do this very often. You ask the PG will tell the CRRA. Like that, the resident told the staff nurse, you prepare this patient today. Unfortunately, there was a change in duties. So the staff nurse, what she had done, the next staff who came was, she shifted the patient from bed 4 to bed 10, bed 4, which is an ophthalmic bed, and bed 10, which is a medical bed, because it was leaking, the roof was leaking there. So next day, the patient, the previous staff nurse who came here, she saw that the patient on bed 4, and she prepared that patient for retinal detachment surgery, who came for mitral stenosis repair. See what is happening over here. What is this scenario called, or this ethical dilemma called? This is communication gap. Very important. Nowadays, the curriculum is attitude, ethics, and communication, ATCOM. So communication skills you have to develop. It is the interchange of thoughts, opinions, information, either in writing, signs. If the staff properly communicated with another staff, or if the resident had properly communicated to the staff properly, then there'll be no dilemma over here. See, some other patient is getting prepared because of the fault of the non-communication between colleagues and faculty. Okay, there are certain things which you should know. That is why I put communication with patient, colleagues, and public. This you will be facing on and off till the day you start medicine to the day you die. This is very important. Use language when you're practicing. These will be very important for you. Like, use common language. Do not criticize other person's actions. Be very user-friendly in telephone systems. Mind you, it is going to be a station for you also here. You have to, a lot of people will contact and get their things done through telephone. Make sure that patients have an emergency access. You should return everybody's calls, and the communication system should be very important for you. So I put up this. Now let me run through the rest of the slides, which all you should know. Competence. What is this competence? Whether if you want to do a certain procedure in ophthalmology, you should be a qualified person to do the procedure. For example, an ophthalmologist. Suppose you are going to do refraction, you choose an optician, that is enough. MBBS now, why I'm talking about this competence? Because now in the recent eye donation forum, before it was only MS qualified can remove eyes for enucleation from a donor. But now they've reduced it to MBBS itself. So anybody with the MBBS can enucleate for a donor for corneal transplantation. See, so that is competence. You have to learn that competence. So competence is a technical ability, knowledge, and ethical concerns for the patient, which you develop as an ophthalmologist. An ophthalmologist, as you know, is educated and trained to provide medical and surgical care to the eyes and related structures. Okay, this is one of the pillars of, one of the principles of research and innovation. Now you're going to be researchers, everyone. Even if you go to undergraduate, postgraduate, you have to keep publishing. This research ethics, you should know this research ethics. You should protect the dignity, rights, and the welfare of research participants. You have to go through IEC institutional review boards. You have to present yourself to ethics committee. You have to give consent forms. All this you have to do for research. If you clear all this, only you can conduct research. So ethical research is very difficult, and you should learn from day one how to do ethical research. Your patient should be the only thing which is in mind, and do no harm. Help the patient, do no harm should be your motto always. Professionalism. This is what everybody is talking about now. Now I see students writing on the board when I'm presenting. See, this is professionalism. Behave as you're not teenagers anymore, you're professionals. So it is an attributes, it is a way you present yourself, it is a behavior, it's a commitment, values, goals, everything which characterize your profession, which is a medical profession, which is held very high. in the society. If you say a doctor, if 3 people walk together and you all are at fault, the policeman catches everyone. He says, who are you? I am this fellow. Who are you? I am this fellow. Who are you? I am a doctor. Doctor, I did not expect this out of you. Why? Because he wants that professionalism from you. I'm wearing a white coat. You go to court. I'm wearing white shirt. That is professionalism. Everything in medical professions is a strong societal role and emotional component. Everything is professionalism. A patient who is suffering, you feel as if you are the patient. That is also a professionalism, because patient gets molded with you. Commercial relationships, you're talking so much. Now it takes 1.25 crores to finish medicine. So much to money to expend. If you want a basic ophthalmic practice, you have to shed at least 15 lakhs. If you want a good consultation room, you should have at least 50 lakhs. If you want a theater, you need 1.5 crores. Okay, so much you have to put in. What are the returns? You shouldn't keep on looking at the returns. They have given you how to advertise, what to advertise, how to present yourself. You cannot go to the pharmacy company. A lot of things are happening. These are ethics only. Pharmacists, pharmacy companies will come and say, I will represent you. I will send you to UK. You can go and come. All you have to do is write my drug. Do you think that is ethics? It is happening. Everything is ethics. Incentive is ethics. You are writing something, they're giving you a bribe. Is that ethics? All this you should think about. And if you want to read it up, go to the net. There is so much of information regarding this. This is the first half I'll take. These are ethics and morals which you should inculcate. There is no laws. But when you come to the second aspect, see, medical legal laws, you are governed by certain laws. You cannot cross this line. Ethics, at least you can get away, not going to jail. But if you get caught in all these medical legal aspects, you can be imprisoned. You can have a hefty sum as a fine. Your name will go off. They can squash you out of the medical council list, and you can practice no more. So you should know. You can never say that I did not know this, because as a doctor, we are expected to know the laws. Everybody expects. The court will never pardon you saying that he did not know the law. No, you should know the law if you're going to practice ophthalmology, or at least you're going to deal with ophthalmic patients. What is this medical legal? See, this, as per the specialty, you can see so many cataract, retina, all these consultants are in soup. They are in trouble because these two big areas, the legal arena and the medical field, get together. So highly regulated is the legal arena, where justice is a central principle, and medical field where eye and vision, they are at balance here. So these two converge into what is called as a medico-legal aspect. See, now so many people, they're filing cases and litigations against all ophthalmologists. These are all the, I'm not telling you the false reading. Everything is from the net, and everything is a true information. Why is it important? Why should you as an MBBS know about this? See, there is an increasing rate of medical malpractice cases which have been filed against doctors. So be very careful when you start your practice from for the first day you say, see, patient-doctor conflict is draining the doctor. You do not know. You should have seen those doctors who, after doing 30 years of service, just because of a small mistake or a mere negligence, their career comes to an end. So it drains their resources. US, somebody gets caught in a medical malpractice, finished. Millions, they sue him, and that's all, he'll become a pauper. Here, after doing, so you lose your satisfaction, your professional, your ego, everything you lose. A strong weapon against charge is a charge of professional misconduct. This always you should know. All these are terminologies which are legally present in medical legal books. Say medical curriculum emphasizes. Nowadays, the previous curriculum, what is it? It just tells you about the clinical competence which you should acquire. Do a cataract surgery. That is all the medical curriculum wants you to do. Learn how to do it. But now it is not like that. Learn how you should admit the patient, how you should evaluate the patient, how concerned you should be, how your attitude should be, how you communicate to the patient, how you get the consent from the patient, everything is important. So not only of the clinical skills, but legal liabilities, communication skills, attitude, ethics, everything comes into line in medical curriculum nowadays. So you have to know this medical legal aspects. The laws against ophthalmology and other practice, yes, Consumer Protection Act is one thing, it is sitting on our head. Code of Ethics and Establishments Acts, then Human Transplantation Organ Act. This governs what you are doing for eye donations and eye transplantations. But this Consumer Protection Act, mind you, everybody is going to face trouble in this. Every patient is going to go to court of law saying that he was damaged or he was not treated properly by his physician. Where are the areas where the patient go and complain? He can go to the consumer court, as I told you, Consumer Protection Forum, very strong. He can go to the police. Police can come and ask you details. You have to provide all the documentation. They can arrest you. They can do whatever they want if he goes and complains. Criminal court, civil court, any liability, you are liable for both. And the medical council, if you have found everything, the patient can directly go to the medical council and he say that he's been damaged because of you. Medical council can even remove your name out of this. See, because of the reason of number of litigations, greater awareness of the patients. Now the media is projecting. So, somebody please mute your, I'm getting an echo. All of you will mute. There is a, see, the patients are more aware because of the newspapers, because of TV articles, because of projections, documentaries, the health cost, everything. They go to a corporate hospital, they pay in tons. So they want to get that amount of benefit out of the cost which they have provided. High expectations. You bluff your way through saying that if you get your surgery done, next day, 6 o'clock, when I remove the pad, you will be seeing the distant ocean. All that expectations patient will expect. Whatever you say, they will expect. Or maybe they will be expecting more. Because of all these reasons, the patient goes to court. What are the common lawsuits in ophthalmology? See, cataract and corneal surgeons are leading here in India. Cataract, I wanted cataract surgery. He was blind previously. He had only 260 or half 60 vision. You have promised a cataract surgery. His patient has lost his vision because of the cataract surgery. He will go to court. Even though he is blind, he expects you to provide vision. That is what a competent ophthalmologist or our peer will do. Or the society expects you to do a good cataract surgery with results. You can have an endophthalmitis, you can drop the pupil, you can do a mesh, whatever you want. Everything comes under negligence. So a lot of us are being sued because of this cataract. Corneal surgeries, and you know, LASIK and other things, developments have come. See, lawsuits usually are due to this medical negligence, inappropriate diagnosis and treatment. Okay, this is one small retinopathy of prematurity. Recently, 2 years back, a patient went to court and the court gave him a compensation of 1.8 crores. Okay, because of the non-diagnosis of retinopathy of prematurity and the child lost vision. Because of non-diagnosis, they did not see, but you know, they went to court and they claimed 1.8 crores. I don't know whether they got it or not, but they've gone. See, what is this medical negligence? Medical negligence is from your part, something which you should have done but not done, which would have been done by competent people of your same peers. Just to make you understand, this is from the patient's perspective. What are the 4 Ds through which he can go to court? See, direct healthcare duty. It is a duty of the healthcare provider to give him the care. See, suppose there is an accident on the road. The patient does not expect you to give him treatment on the road, but he walks into your clinic. You are expected to treat him. You cannot turn him out. If he comes with a glaucoma, you cannot just push him out. But if he's sitting in a restaurant and he's got an acute congestive glaucoma, you can help him. There he cannot go to court or he claim that this is a duty of the physician. No. But in certain places, they expect you to do this. So this is a healthcare provider should have the duty. Dereliction of duty. Whether the patient who comes to you for some duty, you omit certain points or you act too much. All this can be under medical negligence. Direct causation. You do a surgery. Sometimes you can do surgery and flop that surgery. Every surgery is not perfect. You cannot do every perfect correctly. There are certain times of the surgeon, it is the times of the patient, times of the staff, some alternative, something happens and you cause direct injury, the patient can go, claiming that it is your negligence. Here the competence comes also. Damages, patient may come for retinal detachment surgery, but he will develop a cataract. He will go for damages. He'll say that because of this surgery, something else has come. There are certain things, all this I'm not bluffing, because when I was doing my post-graduation, one of my colleagues had removed the retina, a piece of the retina when they were doing cataract surgery. I don't want to know whether he or she, but they means one person only, removed the retina on doing cataract surgery. Is it negligent or not? They can go to court and go. But fortunately, we are having patients who are so poor that they do not understand this. But a middle patient or a patient who's been trained to go to court, they will definitely. So how do you prevent this? There are a number of levels. See, you should have a good setup. I told you the workplace, good OT. Anesthesia is important because a lot of large corporate hospitals, they have an anesthetist. Some people do not have anesthetists and they operate in small theaters. If they lose the patient there or something happens to the patient, they are held liable. And then primary prevention is before the complaint is being filed. That is what we try to do. You have to convince the patient that it is an error which is written in books. For example, endophthalmitis. Endophthalmitis can occur to anyone, anywhere, any place. It can occur in Boston University. It can occur in Madurai Medical College. It can occur anywhere on earth with the highest standards of operation theatre. Even then it can occur. That you should explain to the patient. So he might not go to court saying that, yes, it has occurred to me. What can I do? Then second level was to protect the doctor from being held negligent. Here you should not leave your colleagues. You should not talk ill about your colleagues. All these are ethics also. Financial, you can protect yourself by having endowments policy, insurance policy, against policies. Now you have this PPLLS policy. Everybody should get to, once you finish medicine, you go to CRRA, you are held responsible, means go into this PLSS, some Mediclaim policies, some lot of policies which are there. Go get yourself protected here. See, how do you prevent? Proper case selection, effective communication, as I told you, good medical care, standardized medical care as per textbooks, and you should be very clear in what you're going to do, and very clear documentation. They have written loads and tons of pages regarding documentation. You should know, once you finish and you start practicing, your documentation should be pakka if you want to get out of this medical litigation. I'm going to stop with this. The take home is, you cannot say, I do not know the laws. You have to know. Mind you, I will not face, I am a pharmacologist, so I will not face litigation. No, anywhere you will be facing this problem. But you cannot do away with this. This is our profession. This is what we chose to be. So whatever you do it with passion for that profession, man. With ethical practice. See which is good for you, bad for the patient. And then you choose your morals and then you practice your ophthalmology. God is always with us, Almighty. The teachers are always with us, and blessings of the good teachers like VRV sir and Parthiban sir, we will get through this, or we will become teachers one day, which we have to pass on this message. Thank you for the excellent opportunity, Parthiban sir. And Helen Keller, nobody will ever forget us. See, having the only thing is worse than being blind is having sight but no vision, fusion. They cannot think about the future. But now they are all, you all guys are bright, young. You have to think about your future. Think about a good ethical practice and think about the medical things you're going to face. Be very careful, do good work, and you will always be protected. Thank you for your time. Sir, thank you, sir.
Thanks, Vijay. Thank you. Thank you, Vijay.
Time romba edutitana, sir.
Illa Vijay, that's okay.
Okay.
Vijay, thank you, Vijay. I think that's the take-home message from all the teachers. It's not the subject alone that we learn from our teachers. It's the ethics and the medical legal aspects, which have really been highlighted very beautifully by Dr. Vijay. Congratulations, Vijay. I think the students have really been benefited by your talk. And I think it's a take-home message for every medical student. I think we inculcate more of these ethics into our profession. A lot of the value is being, it's losing its sheen. So highlighting on medical ethics and medical legal aspects. Thank you. Next, I would like to go on to Dr. Prasanna. Prasanna Venkatesh has been is one of the leading and upcoming ophthalmologists here in Trichy, attached to Mahatma Hospital, son of Dr. Ramesh. He's done his glaucoma fellowship at Satyans Institute in Coimbatore. He's currently working as a glaucoma consultant in Mahatma Hospital, Trichy. Gold medalist in MS Ophthalmology and the recipient of SPV Medal for Excellence, graduated from PSG and then from Mahatma Institute. He's been a speaker at various state and national level and international forums. Recently won, I think it should be a real proud moment for his parents when he won the IIRSI award for the best video. So very upcoming young ophthalmologist, excellent speaker, and as you would say, a trendsetter, a person who's a very lively personality. Thanks for participating, Prasanna. On to you, Prasanna. Thanks. The stage is yours.
So thank you. Thank you for the kind words, sir. I hope I live up to the expectations. Is my screen shared, sir?
I am.
Sharing. Screen.
Names.
1 second, sir. I'm just trying. Now is it on, sir? My screen? Yeah. Thank you. Sir, I would like to use this opportunity to thank two of my teachers who are also part of the speakers here. First is Parthiban, sir. Though I did my MBBS in PSG, I got transferred and came and did my internship in Trichy KAPV under Parthiban, sir. The one thing நான் அப்ப சொல்லல sir, but ஆனா எல்லா டிபார்ட்மெண்ட்லயுமே வந்துட்டு we used to work as interns and we used to leave. But ophthalmology la mattum, I remember after the 15 days of internship, you made us do some topic, choose a topic, present the topic, and you moderated the topic and made sure that we took some points out of not only the work, but academic-avum, do you take some points away from it? அப்படின்றது வந்து it was a very great thing, sir. And the time being an intern, it was a very, very great experience for me to be as an intern for 15 days under you. Vijay Raghavan sir came there and guided us on how to go about the practical part of it. So I thank you both. And I would like to start my topic after two great lectures from two eminent speakers. Am I audible, sir? Audible arika, sir?
Yes.
Yeah. Okay. So the topic is on glaucoma, basically from an undergraduate point of view, touching a few points on the postgraduate level. So when 2 days back, undergraduate students, two students came to give the certificate regarding the invitation. I was just asking them what they would like to expect from me regarding glaucoma. Because personally, for me today in glaucoma, I use this Inception Penrose steps. The place where you start is the place where you are going to end. So even my mentor, Satyan sir, used to tell me, today, after 20 years of practice in glaucoma, I still feel I only know about 10% of the whole glaucoma. So I'm just only 2-3 years old in the specialty. So for me personally, glaucoma is still something like the Penrose steps. You feel you have conquered the disease, but again, you just end up at the same place where you actually started. So from the undergraduate point of view, when I was an undergraduate, glaucoma, abdina, this used to be that face expression that I used to get when I was an undergraduate. So I can imagine what you must be going through, my fellow undergraduates, as well as postgraduates, first year, second year, still that glaucoma, diloma will always be there. So basically, the definition of glaucoma is the chronic progressive optic neuropathy. That is the optic nerve that gets damaged progressively and followed by an irreversible visual field defect. So this is what is something that we are ascertaining upon is In cataract, the visual field defect can always be recovered. We can always satisfy the patient after the cataract surgery. But in glaucoma, the problem is the visual field that is gone is gone. We cannot recover it. So that is the second part of the definition. And the third part of the definition is the patient can present with raised intraocular pressure. The important point here is frequently but not invariably. That means they can or cannot present with raised intraocular pressure. So this is a very important thing. I've just made sure my slides are catering to your 2-mark or the 10-mark questions that you will be having, so that you will benefit both practical point of view as well as from your exam point of view. So these 3 points are very, very important. The chronic progressive optic neuropathy, the irreversible visual field defect, and the raised intraocular pressure, which is frequent but not invariable. And this is use most of my own patients' images for better learning. So on the left-hand side of your screen, you can see a normal disc with a normal cup. You can see a vertical oval disc with a cup in between. The cup is, you can see it's pink, or you can say it is whitish yellow here in the center, which is very small. And on the right-hand side, you can see this is the disc, which is having a complete loss of the neuroretinal rim tissue. So this is how a glaucomatous end-stage patient will actually look. So this is a comparative picture showing what is normal and what is abnormal. So from an undergraduate point of view, this picture will serve you to diagnose between what is normal and what is abnormal. That is a glaucoma point of view. And what is glaucoma? It is nothing but the cupping. So you have the cup, which is 0.3. What happens is in glaucoma, the vertical enlargement of the cup takes place with the loss of the neuroretinal rim tissue, as you can see on the left-hand side of your screen. So this is a cup. The green line is the cup. From the top to bottom, you can see the cup is marked, and the blue line is the disc. So the cup is 0.74 and is glaucomatous on the left-hand side. And on the right-hand side, you can see the cup is a 0.72. So this is what is cupping. So when somebody says cupping, when your postgraduate says cupping, don't get startled. It is the cup is the increase in the distance of the cup, vertical diameter. That is what we say is as glaucoma. And sometimes, even if the cupping is only 0.3, still it can be glaucoma in rare instances. As in this patient, you can see that asymmetricity of the cupping is very, very important. So you can see the right eye, it is almost, there is no cup. And in the left eye, if you see, there is a 0.3 cup. This is all signs of early glaucoma changes that are setting in for the patient. So we should be very careful. Again, for postgraduate, this slide will be very important, that this is also part of a glaucoma spectrum. And this is one of my slides where I feel just pay some concentration for this slide. I think you can answer a lot of 5-mark or 10-mark questions with this particular flowchart that I have devised specifically for you. So on the top hand side, you can see cupping, glaucomatous cupping plus glaucomatous visual field, plus if the intraocular pressure is greater than 21 millimeters of mercury, then the patient can be a primary open angle glaucoma or a primary closed angle glaucoma. That you can only differentiate whether it is open or closed by doing gonioscopy. That is the first important point. If you have a primary open angle glaucoma question, you can answer this 3 spectrums and write the question very beautifully. And the second mapping, one is the patient is having glaucoma cupping followed by glaucomatous visual field, but the intraocular pressure is constantly below 21. That means the patient is still having glaucoma, but it is a normal tension glaucoma. So that is the difference between what do you say as an open angle or a closed angle primary glaucoma, and what do you say is a normal tension glaucoma. So that is a point number 2. And point number 3 is patient is having a normal disc, no cupping, no glaucomatous cupping, and he's having a normal visual field, but the intraocular pressure is greater than 21 millimeters of mercury. Then it is defined as ocular hypertension. He's just having pressure in his eye, but apart from the pressure increase, there is no cupping, no visual field. So I just use it as a template because you can try to cover 3 important topics, and whatever the question that you may have, this will serve as a template for you to answer that question. Because in any question regarding glaucoma, you need to make a comment on the disc status, the visual field status, and the intraocular pressure and the angles. So moving on to the next template. So we now talked about open angle or closed angle. So how will you say whether it is a primary open angle or a primary closed angle glaucoma? You need to do a gonioscopy, which is very important to distinguish whether the angles are open or not. So what is an angle? That some of your neophytes will be having the doubt, who are newly entered into 3rd year. What is the angle? Angle is nothing but you have the cornea here and you have the iris inserted here. So the difference, the distance, the angle is the angulation between the cornea and the iris, to have it in a layman's term. As you can see in the picture here on your left bottom side of your screen, on the left hand side you can see the angle between the cornea and the iris is very much open, which is an open angle. And on the right hand side you can see the angle between the cornea and the iris is occluded. It's more of shrunk like this. So that is a closed angle. So that is when you differentiate that, now you can say this is an open angle glaucoma or this is a closed angle glaucoma. So now, to complicate things further, sometimes you may have a question regarding secondary glaucomas. So how will you approach those kind of questions? Don't get startled. Just make sure you pay focus for this slide alone. You have cupping. You have a visual field defect of glaucoma. The intraocular pressure is greater than 21 millimeters of mercury. You do a gonioscopy and you find that the angles are open and there is no secondary cause at all. Then it is nothing but primary open angle glaucoma. That's it. So this is covering all the major points for a primary open angle glaucoma. The second template, you have a glaucomatous cupping, you have a glaucomatous visual field, the IOP is greater than 21, the angles are open, but there is a secondary cause, like you have some pseudo exfoliation material deposited on the angle structures. Those are all comes under the spectrum of secondary open angle glaucoma. Now moving on to the third template, you have glaucomatous cupping, you have glaucomatous visual field, you have the intraocular pressure greater than 21 with a closed angle with no secondary cause. No secondary cause has been identified. Then it comes under primary angle closure glaucoma. And finally, for the fourth template, glaucomatous cupping, visual field defect, intraocular pressure greater than 21, closed angles with a secondary cause. You have a secondary cause, as Captain Vijayaraghavan sir was beautifully pointing out. When you give a topiramate, there is always a chance of the ciliary body swelling to push the iris from behind and cause a secondary angle closure glaucoma. Those are all secondary angle closure glaucomas. So that is the final template. So with this template, I created especially for the Oculofest participants, because if you have any 5 mark or 10 mark with this template, I feel you can answer any question beautifully. So keeping in point how to score marks in your exams, that is why this template was constructed. You can take a screenshot if you feel it is worthwhile. Yes. So angle is something that we keep on re-emphasizing, angle of the anterior chamber, angle of the anterior chamber, because in glaucoma, as a glaucoma practitioner, the only modification that we can try to do is reduce the intraocular pressure. We cannot have any control over the visual field changes. We cannot have any control over the morphological changes. The only thing that we have a control on is the intraocular pressure. And the only way we can do it is we can try to create some changes in the angle, because that is how we can make the pressure to reduce by making the aqueous go out more or make the aqueous drain more. So that is why we keep on targeting the angle in majority of the discussions. So we already showed what is an open angle and what is a closed angle. So approaching glaucoma holistically is very, very important. We just cannot talk about only one dimension and say this is what glaucoma is. So the first thing I would like to emphasize is the intraocular pressure and clinical examination. So this is the iris here. You can see that, as you can see my arrows here, this is the iris and this is the cornea. So the black part here is the angle. So this is an animation showing how the angle looks. So you can see that this is the angle structures that appear in an animative way. So in real time, so every pathology that happens in glaucoma is majoritively concentrated at the angle structures. So we try to make sure we target the angle structures for treating. So that's how we can try to cure it. So from an undergraduate point of view, this is what that basic for examination, it will be expected from you. Basically, you will be provided with a torchlight. That is what you all will be having. So in a torchlight examination, how do you go about assessing the angle, which is not that easy because angle cannot be seen on a torchlight, but this is what is somewhat expected from you. This is called the tangential flashlight screening method. So what you need to do is, you need to take the torchlight tangential and throw the torchlight from the temporal side of the patient and see how much the light is traversing onto the nasal side of the patient's cornea or the anterior chamber. So see, for example, imagine it if the patient is having a deep chamber, as seen in the left-hand side figure here. When you throw the light from the temporal part, the chamber is predominantly illuminated because the chamber is very deep. The light travels up to the nasal side. Whereas if you take a shallow chamber, which is predominantly very common in hyperopic patients as well as in Asians, what happens is when you throw the light from the temporal part, the temporal iris is actually already convex and it is bulging. So it doesn't traverse to the nasal side, as you can see a shadow here. So this is called the eclipse sign. So this is something that is very important It will be asked in your practical examination with a torchlight how you can say whether it is a deep chamber or whether it is a shallow chamber. Once you have diagnosed what is a deep chamber and what is a shallow chamber, you can come to somewhat a conclusion that a deep chamber eye will almost always have a wide angle, and a shallow chambered eye will almost always tend to have a narrow angle. So that is how the undergraduates can come to a conclusion about the angle status. So what happens, why we keep on talking about angle is, as we age and being an Asian preponderance, there is always a chance that we have more of this angle crowding. So see this animation, you can see the lens here. As the lens increases in thickness as we age, you can see the angle here, which goes in for an occlusion. And suddenly you have this iris and lenticular contact, which is the pupillary block phenomenon. And you have a patient presenting with the post-acute angle closure attack. So there is another question here which will be asked, what is the triad of this post-angle closure attack, which you all should be prepared for the examination. So this is a clinical picture of the patient of a post-angle closure attack who has a 360-degree pupillary block phenomenon that takes place as you see in this video. As you can see, when the lens increases in thickness, you can see there's a pupillary block mechanism and the angle is going in for a occlusion, causing the attack to take place in the first instance. So this is very important for undergraduates. Always have the triad. I'm not talking theory, but make sure you read the triad of the post-angle closure attack. And then what we need to do is, again, this is one of my patients, ASOCT, where you can see the angle here. Just make sure you concentrate on my arrows. The angle is occluded. So this is one of a bilateral acute angle closure patient. Once you do a YAG PA, what happens is you can see that the angle is now broadened. So the angle which was crowded like this, now it broadened and opened. So that is why YAG PA. So many people will be having this question, the undergraduates, why they are doing the YAG PA. Whenever there is a pupillary block or whenever the surgeon anticipates a pupillary block, a YAG PA will be done to deepen the chamber or to deepen or to push the iris back from the cornea. That is why you do the YAG PA. Another important examination that you need to keep in your mind is, make sure you lift the upper eyelid and ask the patient to not look down, or make sure you lift the upper eyelid and see for the YAG PA in the torchlight. That is very important in your glaucoma case, which you should not miss. That is very important. Make sure you note the YAG PA, which will be predominantly at the 12 to 1 o'clock position. For the postgraduates, this is for the postgraduates, use the peripheral anterior chamber angle assessment method by the slit lamp technique. Put the slit and make sure you assess the posterior anterior chamber angle by making a difference between the anterior chamber depth and the corneal thickness. You can see if the corneal thickness is equal to the anterior chamber depth, then the angle is very well open. If your corneal thickness is greater and the anterior chamber depth is smaller, that means the angle is going in for a occlusion, or it is more of a closed angle. So this is very important. I'm not talking about the grading. This is given in the book, but make sure you read it up. So this is the angle anatomy animation for the undergraduates. For you may have a question on what are the angle structures, and please arrange them from anterior to posterior or posterior to anterior. So this is an animation of the angle structures where you can see anteriorly you have the cornea. So this is the Schwalbe's line, and then you have the trabecular meshwork, which is non-pigmented, and trabecular meshwork, which is pigmented, followed by the non-pigmented trabecular meshwork. And then you have the scleral spur, then you have the ciliary body band, and finally we have the root of iris posteriorly. So majority of the drainage happens where it happens in the trabecular meshwork. That is very important. This point is a very important point. The aqueous drainage happens through the trabecular meshwork. So that is a take-home point from this slide. Then in real time, this is for the postgraduates. In real time, how does the angle look? So in the real time, if you see, I've just paused the video, right hand side, just focus on the video. The arrow here shows the Schwalbe's line. The pigmented line here is the Schwalbe's line. How will you demonstrate the Schwalbe's line will be a question asked to you. Use the corneal wedge technique to demonstrate it. Then after the Schwalbe's line anterior, you have the trabecular meshwork, which is non-pigmented, followed by the trabecular meshwork pigmented. Then you have the scleral spur, then followed by the ciliary body band and the scleral and the root of the iris. So this is for the postgraduates. Then you have two grading systems. One is the Shee's grading system. This is an animation of Shee's grading. And then you have Schaffer's grading system. This is a theoretical question that may be asked for both undergraduates and postgraduates. So just giving a small brief on the Shee's grading system. Grade 1 means all the 4 angle structures are seen, it is very well open. As you go 2, 3 and 4, one structure starts to get decreased. In grade 2, you have only 3 structures. In 3, you see only 2 structures. In 4, only 1 structure is seen. It's a reverse way around. And in Schafer's grading, it's exactly the opposite. Here, the grade 4 means the angle is wide open, and grade 0 means the angle is completely locked. So whenever the grade is 0, that is where, if the pupillary block is responsible for the grade 0 angle, that is when we do the YAG PA and make sure we release the relative pupillary block mechanism. And only when a gonioscopy is done, 2 things we can come to a conclusion. My dear postgraduates as well as undergraduates, please make a note of this. You can differentiate an open angle from a closed angle only by a gonioscopy. And second thing is, the secondary cause of a glaucoma can always be ruled out only with the help of a gonioscopy. So these are some examples of secondary glaucoma. Pseudo-exfoliation material is beautifully seen deposited on the lens here, and in the angle you can see the pigmented angle structures. And this is a pseudophakic patient of mine, where you can see the fibrillar pseudo PXF material beautifully floating into the anterior chamber, and the classical Sampolisis line. Again, this can be a neat question for you. The right hand side and the left hand side pictures. This is how a Sampolisis line look. You can see this curved lines here. These are the Sampolisis line which you need to keep in your mind. It can come as an OSCE also. And pigment dispersions in glaucoma. So this pigment dispersion is what is, there is a lot of pigment dispersion which happens because of the iris rubbing with the lens behind and causing this pigment dispersion. So on the cornea, you can see there are a lot of pigment dispersed, as well as you can see a glaucomatous cupping. And if you focus on the angle, you can see a lot of dense pigmentation. So this is for the postgraduates, the secondary glaucoma questions and all. So you can make sure you write the questions very well, or even answer it theoretically. Another important thing is, any patient comes with trauma. So this is one of my patients who came with a trauma, and he was perfectly normal. There was no signs. Vision was 6/6. There was no issues at all for the patient. But when gonioscopy was done, you can see that this is a ciliary body band which is broadened. A broad ciliary body band is a sign of angle recession, which can cause glaucoma immediately, or it can cause glaucoma very later in his life also, where there are toned iris processes and the ciliary body band is very broad. So this is a video showing that particular instance, where you can see the iris processes are torn, and this particular brown dense band is a ciliary body band. So always, whenever the patient comes with a trauma, vision may be 6/6, intraocular pressure will be normal, anterior segment will be normal, fundus will be normal, but the angles can or cannot be normal. So you need to do a gonioscopy for all the trauma patients. That is very important. And this is one of pediatric patients, where patients will have aniridia, a condition called aniridia, where there is no iris at all. So it is actually kind of like a misnomer, where there is some part of an iris tissue which is remaining. So you can see this is angle structure. As you can see the arrow here showing the iris stump that is remaining. So this is the root of the iris stump that is remaining, and this is the ciliary body band. So people who have not seen a ciliary body, which is slightly behind the iris, so this is how the ciliary body which looks, which is a very plicated orientation like structure. So I'm just focusing on trying to orient you towards the normal phenomenons and slightly abnormal phenomenons, because it's all are mostly beginners, and I would want to orient you towards the basics. So moving on to the next thing is the intraocular pressure. So intraocular pressure is the only thing that we can control as an ophthalmologist, because we have no control over the other parameters. The disc damage cannot be reversed, the visual fields cannot be reversed. Only thing that we can control is the intraocular pressure. How we can control the intraocular pressure is by 3 mechanisms. One, either we have to prevent the formation of the aqueous. By reducing the formation of the aqueous, we can reduce the intraocular pressure. Or 2, we have to increase the aqueous to go out of the eye. That is 2. And the third thing is, which is a very passive phenomenon, which is the episcleral venous pressure, by the phenomenon of PV here shown here, episcleral venous pressure. Yesterday, one of the undergraduates was asking me, what is the role of episcleral venous pressure in intraocular pressure? I told, see, in thyroid orbitopathy situations where there is proptosis, the venous stasis takes place, and it has an indirect role of causing an occlusion on the episcleral veins. And by causing an occlusion on the episcleral veins, then the intraocular pressure shoots up in these kind of an eyes. That is very rare, but again, you need to know about that also. So majority of the drainage takes place through the trabecular meshwork only. That is a conventional drainage. So how do you go about measure it? So there are 2 important things that you need to know. One is an applanation tonometer, Another one is an indentation tonometer. So when you use an applanation tonometer, the only point that I would want you to have in mind is the two Myers, when you applanate, should make sure that they intersect each other at their inner edges. So as you can see on the left hand side, they should intersect each other at their inner edges. That is very important. So that is how in applanation tonometer you come to a conclusion. And I can see a dial here. What is the reading of the dial? Multiply it by 10 and you get the pressure. So that is something that you need to keep in your mind. And second thing is the Schiot's tonometer. In Schiot's tonometer, there are many different weights. Predominantly, you'll be oriented to 5.5. That is what commonly you'll be using, or maximum 7 you'll be using. So in Schiot's tonometer, what you do is first make sure that tonometer is calibrated, because in workups nowadays, undergraduates, interns, postgraduates, everybody will be using a Schiot's tonometer maximum. So make sure you check whether it's calibrated first, and once it's calibrated, keep it on the eye. What is the reading that you get on the grading here? Make sure you note that reading. And then what is the weight that you are using? For example, you are using 5.5 gram weight and you get a reading of 5 in the grading. Then 5.5 and 5, 17.3 is the intraocular pressure, which is normal. So these two, everybody expects both the undergraduates and the postgraduates to know. But the main principle here is in applanation tonometer, you can see that it's only a small indent of the cornea. It is just a mild touch. Whereas in indentation, you can see that there is a big dent here. That is the difference between applanation and indentation. That is the reason why applanation is the gold standard and not indentation, because indentation tonometers can falsely press and raise the intraocular pressure. It may cause a high intraocular pressure phenomenon, but in reality, the patient may not be having such high pressures if the experience of the examiner is not great. That is the problem with indentation tonometers. As you can see, again, this is a real-time picture of left-hand side. You can see the applanation, which is very smooth. In the right-hand side picture, you can see the indentation, which is slightly like a poking phenomenon, where you can see that the aqueous is displacing more, causing a falsely raised intraocular pressure. And the second thing is the central corneal thickness. This is purely only for the postgraduates. There is a correction factor available. Whatever central corneal thickness you get, make sure you correct the intraocular pressure according for the central corneal thickness. The simple phenomenon is if the CCT is lower, then the IOP that you have got is also low. You should add, use a correction factor and add it, and then get the intraocular pressure. And similarly, if the CCT that you get is high, then make sure you use a subtraction factor and then reduce the intraocular pressure, and that is the original intraocular pressure. So this is a classical phenomenon for my postgraduates who are attending. The top side picture is a keratoconus and the bottom side is a normal patient. In keratoconus, what you expect is you have a thinner cornea. So what happens in a thinner cornea, you can see both the patients are having the same intraocular pressure. But in keratoconus, since the cornea is thin, you can see the cornea is going in more compared to the bottom picture where the cornea is not going that more inside. In an example of a non-contact tonometer, this picture. So this is a role of cornea and intraocular pressure. Always never underestimate the power of cornea. This is also a case of keratoglobus, where you can see that whenever the cornea is thick, the applanation and indentation will be so variable. So this may also come as one of your questions for postgraduates especially. Moving on to the fundus photo. Glaucoma fundus is one of the most important factor we saw in the definition, progressive optic neuropathy. So left-hand side picture is normal, right-hand side picture, the patient is having glaucomatous optic nerve cupping. So this is how a cupping will look. And not only the cupping, the intradisc changes is the cupping. The peripapillary changes also is very important, where you have an atrophy. You can see the surrounding areas here. It is called the peripapillary atrophy. So these are some changes that they will expect you in exams. One is the increased cupping and laminar dot sign, where you can see some dots, which is nothing but the sieve-like structures of the sclera. And then you can see the nasalization of vessels and the peripapillary atrophy. This point is very important in the disc changes. Moving on to one of my patients, in my fellowship periods, the patient right-hand side picture is also only 0.3 cupping. But postgraduates, keep in mind always when you have a baseline picture of something like a 0.1 cupping in 2013 year, the 2017 picture after 4 years, if the cupping is increased, this is a glaucomatous sign. So this is something very important. We are now moving towards documenting even small cupping, so that if the intraocular pressure is high and the patient has a chance of developing a glaucomatous cupping in the future, we can still diagnose it beautifully with fundus photographs and a good clinical diagram too. That is very important. And then these are next few slides are only for postgraduates, where you can see that The RNFL defects are something that examiners expect you. They stand near you and see whether you are using the red-free filter of your direct ophthalmoscope. If you are using a direct ophthalmoscope, if you have a glaucoma case, postgraduates, make sure you use your red-free filter and see the RNFL. That is very important. You can have a superior slit defect. You can have an inferior wedge defect as seen in this example. And this is another example where there is an inferior wedge-shaped defect. Always use a red-free filter. Only with the red-free filter you can see the RNFL or the retinal nerve fiber layer beautifully. This is an arcuate defect which is seen, an RNFL defect. And then this is again another slit defect seen inferiorly as well as superiorly. And this is a case of diffuse RNFL defect where you can see the choroidal vessels also, which is beautifully seen underneath. And this is again one important OSCE or one important question that they can ask you. This is a right hand side picture where you can see that the disc is actually mimicking like a pale disc, but this is not glaucomatous disc pallor. This is a neurological pallor where the patient is not glaucomatous, but the neuroretinal rim is pale because of a neurological condition rather than a glaucomatous one. This will always be an important 5-mark question for undergraduates or postgraduates. How will you differentiate between glaucomatous disc pallor versus neurological disc pallor? Keep in your mind, very important. So cupping will not be there, but only pallor will be there. That is a very important take-home point. So the visual field is again another thing which is very important in glaucoma, because as I told you previously, glaucoma should be approached holistically. So Traquair described the visual field as island of vision in a sea of darkness. So why it was called as an island of vision is it's basically a 3-dimensional representation which is seen on top of a 2-dimensional phenomenon. So it is a 3-dimensional representation of what you see. And this is a very important question which will be asked for anybody, be it the undergraduates or the postgraduates. What is the extent of your normal visual field? So make sure you have this in your mind. Temporal is always the most wider one, and superior is 60, inferior is 75, nasal is 60. So make sure you have this particular value in your mind. This will be asked in your exams. So from an undergraduate point of view, the only thing that you need to keep in your mind is what are the different visual field defects that occurs in glaucoma. So that is the thing that you will be getting as a question in your exam. So what can occur is, majoritively what happens is you have blind spot. You can see a paracentral scotoma here, which is near the center, or sometimes you can see a nasal step, and sometimes there is a diffuse contraction or an isopter contraction. Once the paracentral scotoma joins with the blind spot, you call it a cedial scotoma. And then when it starts to enlarge and touch the horizontal meridian here, it becomes an arcuate scotoma. Arcuate means it's like a bow. Bow is what we call as arcuate. When you have two arcuate, one on the top and one on the bottom, it is called a double arcuate scotoma. So these are some of the things that you need to study. Theoretically, you may be asked these questions. And another one important question, which is a favorite question for many examiners, would be a patient has a tubular vision. He is seeing through a tube. Now what will be the visual field strategy that you want to do? In glaucoma, majoritively we do only 30-degree fields. The central 30-degree is what we usually study. But when the patient has a tubular vision, then we need to go for a central 10-degree analysis of the visual field, because he has already lost his peripheral vision and only the center tube is remaining for him. So this is a very important point to keep in mind. And 2 points that I would just touch upon and not go into the depth of visual field is, one is the mean deviation, another one is the pattern standard deviation. Visual field itself is a different topic altogether. Just touch upon only these 2 points. As you can see here, there is a mean deviation here, the chart here, and there is a pattern standard deviation. Make sure you orient yourself to the complete visual field analysis, but only these 2 take-home points that I felt was worthwhile in this quick time which I can share is, one is a mean deviation where all the points are reduced, generalized. It's a generalized reduction. Whereas in pattern standard deviation, only focal points are reduced. So how does it apply in real practices? When you have a cataract, then you will have a diffuse defect where all the points will be generalized reduced. But in glaucoma, what happens is there is a localized reduction. So in real-time situation, mean deviation will be reduced in cataract, whereas in glaucoma, you may have a mean deviation reduction also followed by a pattern standard deviation also. That is one of your favorite exam questions which will be asked for you. And final parameter of today is the OCT retinal nerve fiber layer analysis. So we saw the normal neuroretinal rim is what is the ISNT rule, which is a very favorite 2-mark or a practical question where inferior, you can see the red markings here to make sure you follow it. I've just used these markers on my screen. So the inferior neuroretinal rim is thicker, followed by the superior neuroretinal rim, followed by the nasal neuroretinal rim, followed by the temporal neuroretinal rim. This is very important for you to keep in your mind. I is greater than S is greater than N is greater than T. This is called the ISNT rule. And this is a retinal nerve fiber layer. So we were talking about all the retinal nerve fiber layers, which comes in and dives into the optic nerve. So it's like this waterfalls picture here, which I'm showing. The nerve fiber layer comes and then dives into the optic nerve. So this is again another animation picture, which I wanted to show to make sure you understand the concept of how the retinal nerve fiber layer comes and dives into the optic nerve. So how does it apply? So when you see on top, this is what you look, but in reality in 3-dimensional on the left hand side, this is what it is. So in the OCT, what we do is we do a 360-degree analysis of the neuroretinal rim. So this is a normal disc with a normal cup where the neuroretinal rim is normal. So this patient is perfectly normal. In glaucoma, what happens is you can see an inferior temporal notching here. That is, the cupping has taken place and the neuroretinal rim has reduced in size. So in this situation, you can see that it is constricted. You can see that there is a red line here showing that there is a loss of tissue. So in this inferiorly, when there is a defect, there will be a superior visual field loss. When there is a morphological inferior defect in the optic nerve head, there will be a superior visual field defect in the functional fields. That is very important for you to have in mind. Whenever there is an inferior defect in the optic nerve head, there will be a superior scotoma. So that is how the things get relayed onto the retina. And finally, touching few points on the medical management, only a single slide, because again, this is a detailed topic of it. But some of the beautiful points already, medical legal aspects was shared by sir regarding the prostaglandins, beta blockers. I personally feel beta blockers is slightly costlier than the prostaglandins is the first line drug, but it's slightly costlier than beta blockers. If you have an affordable patient, then you give prostaglandins. If the patient is not affordable, try to not tax the patient, try to start him on beta blockers, and then we can work on it from there. If the IOP doesn't control, we can try to add another medication. Again, the alpha agonist and carbonic anhydrase inhibitors will always be a secondary add-on drug according to my preference. First line preference will be a prostaglandins or a beta blocker, followed by alpha agonist, carbonic anhydrase inhibitors. Pilocarpine is not frequently used, but still it has a role where whenever you want to do a YAG PA, you give pilocarpine and you constrict the pupil, and then only you do a YAG PA. So still it has a role, but for medically managing the patient, its role has now comparatively decreased. So you need to have all these 5 drugs in your mind for an exam point of view. And there are other 2 drugs also like glycerol, mannitol. It's all theoretical, but please do study about those drugs also. And finally, let us see about the surgical management. We talk about trabecular meshwork. That is the only place where the aqueous goes out. So trabeculectomy, where we try to make sure we do a punch there and make sure we create a bypass system in the eye to make sure the fluid inside the eye comes out into a subconjunctival space. That is why when you examine a glaucoma case, these are some points you need to keep in your mind. Push the torchlight and see whether the chamber is shallow or deep. Ask the patient, lift the upper lid and see whether there is any PI, YAG PA or surgical PA. Ask the patient to look down, because only when you ask the patient to look down and lift the upper eyelid, you can see this bleb, the white fleshy elevation, which is called the bleb. That is where we make the opening and the fluid comes out and drains into that area. So these are something that you need to keep in your mind. And my dear fellow postgraduates, when you examine a glaucoma case, especially a bleb, which is a mitomycin C bleb, always you should make sure you stain the bleb and see whether the bleb is leaking. That is again very important from a practical point of view. If it is a mitomycin C bleb, that may be expected from you from an examination point of view. Stain the bleb and use a cobalt blue filter. This is one of the short steps that I have shown in trabeculectomy. Once the conjunctiva has been cut, put a triangular flap on the sclera and you undermine the trabeculectomy, partial thickness flap. It's not a full thickness one. It's a partial thickness flap. So once it has been undermined, the triangular flap has been undermined. Now what you need to do is make sure, these are the steps of the trabeculectomy surgery I'm just showing you. So once the triangular flap has been taken, then enter into the anterior chamber with a paracentesis blade. Once the entry has been done, this is the punch that we are talking about. This punch is the most important step where we make sure we create an opening or an internal ostium that has been created. So once the punch has been made, a PA is being done, and then the sutures have been placed. And this is one of trab with Ologen cases that have been done. There are a lot of things that can be asked in your exam. Mitomycin C is one, 5-fluorouracil is one, Ologen is one of the newer techniques that has been operated by surgeons, and so on. So trabeculectomy is something which is a commonest surgical procedure and you need to know about it. And second thing is, for the postgraduates, gonioscopy is very important in your examination. Never avoid doing a gonioscopy. If you have a trabeculectomy patient, this is how the internal ostium will appear to look when you do a gonioscopy. You can see the ostium here. So this circular horizontal oval here is the ostium, and you can see a PA also here. So this is how an internal ostium will look on gonioscopy examination. And finally, there is another surgery called a tube surgery. If the glaucoma is very resistant, despite whatever trap we do, whatever medical management we give, the patient ends up with severe intraocular pressures, then we go in for a tube placement, where you can see on the left-hand side of your screen, this is an Axenfeld-Rieger syndrome. That is why the iris appears to be more distorted with a lot of polychorias. And you can see the tube is beautifully placed. And on the right-hand side, you can see the tract of the tube. So this is how the tube scenarios look. And this is a case of an express shunt, not very frequently used, where you can see that this is a microinvasive glaucoma surgery, where a mini tube is placed in the angle structures. And then finally, despite all the measures, you have that IOP is still not getting under control. You did a trabeculectomy, you did a tube, still the IOP is not under control. There is something called a diode cyclophotocoagulation, where thermal energy is used to destroy the ciliary body. The ciliary body is the one that forms the aqueous in the first place. That is now destroyed. So now once that is destroyed, now the eye doesn't have any scope for a aqueous formation. So you can see this is a Miyake apple view. Miyake apple view means the view that happens when you see from inside the eye. So when you see it from inside the eye, this is how cyclophotocoagulation procedure appears. When you keep the energy and destroy the ciliary body. So these are some videos showing how the ciliary body is destroyed. So this is a destructive procedure where the ciliary body that forms the aqueous humor is destroyed. And now we have a latest technology called the micropulse technology. It just like a massage where it just applies a micropulse wave and it slowly modulates the ciliary body. These are all ciliary body procedures. Just make sure you know the name alone, which will be very important in some recent advances question that may be asked you. So with that, I think I try to cover glaucoma in a comprehensive nutshell for majoritively for undergraduates and postgraduate point of view. I just have some, Parthiban sir, I have just some 5 images, sir. Can somebody answer or shall I answer it myself, sir?
Let's see whether they will be able to do it. Share it here.
Yeah. So these are some photo quiz. I've used this Inception from Nolan. I'm a huge fan of Nolan. I think 26 or so maybe.
I know. Nolan would be a fan following.
So,
okay.
So actually some questions are undergraduates, some questions are postgraduate. Just 5 pictures I have, sir. So if anyone is willing, I think they can try to go ahead and answer it. PGs from KAPV. Anybody's want to unmute and you want to have a go at this?
Let's identify the thing. What is your question?
Anything, sorry, I just gave the answer there. So anything, sir. Identify this one here, the arrow here, which is, or whatever the condition that they feel this could be maximum. The right hand side, the arrow that I'm just showing here, sir. The inferior red color thing. Any PGs are ready, sir, to answer?
Shruti Neela. Shruti is not supposed to answer.
Shruti,
she's getting ready for the next topic.
Okay.
There's this thing chat la paru, Prasanna.
Chat
la irukku.
Splinter hemorrhage, yes, correct. So, yeah, that's the right answer. And this comes in a condition predominantly where there is a normal tension glaucoma. You tend to note this splinter hemorrhage. And from a PG point of view, signs of a splinter hemorrhage is a thing that shows that the glaucoma process is more active. So we need to evaluate this patient by a carotid Doppler, cardiac echo. Make sure you rule out other secondaries, especially if it is a unilateral condition. And even obstructive sleep apnea is one of the causes. So postgraduates, please make a note of all these causes. And this is a very straightforward one. There was no rise in intraocular pressure, but still you can have rise in intraocular pressure with this kind of a secondary phenomenon. Anybody wants to go ahead, you can answer in the chat box also. What do you think this condition is? Okay, I'll for want of time, I'll say the answer. It's just a foreign body which was in the eye for an inert foreign body for a long time. We did not cause any problem at all, and the patient also did not present once immediately after the foreign body. So it's an inert foreign body. Lucky for the patient, there was no secondary inflammation or glaucoma. And this is one of the third questions. Anybody want to take a go at this question? So again, one of my patients, you can see a central white lesion on the cornea, and the iris comes and attaches onto that central white lesion on the cornea. Any postgraduate?
Adherent glaucoma.
Adherent glaucoma, not a bad try. Now go for a, you told an acquired condition, now go for a congenital condition. Try a congenital one. I'll give a
no, that's not seclusive.
No, sir. I'll give maybe a clue.
Good.
Stumped வந்து வருங்க. Stumped. Okay. Chat எப்படி ஓபன் பண்ணனும்னு தெரியல. இதுல?
Yeah, அதுல chatting கீழ இருக்கும் பாரு, ஸ்கிரீன்ல கீழ இருக்கு பாரு.
ஒரே செகண்ட் சார். chat ஆமா.
ஸ்கிரீன் கீழ இருக்கு.
ஆமா சார். pseudo explain staphyloма, RB, seclusive.
It's not actually.
Leukoplakia. Okay, I'll tell the answer. Okay, this is இது வந்து the
leukoplakia எல்லாம் யார் அது பயங்கரம்.
Okay, this one is the anterior segment when it forms when there is an improper cleavage. This is called a Peters anomaly. So this is a classical case of a Peters anomaly. Please read on that also, dear undergraduates and postgraduates. I think you have something called a stumped. Stumped light is one of the spectrums. STUMPED. So this is where the iris comes and attaches on the central cornea. This is a classical example of a Peters anomaly. Then this is another thing. You bring patients from the camp. Suddenly the mature cataract patient has a red eye. So I've given you another clue on the right hand side bottom of your screen for the anterior chamber depth assessment. The reflection on your cornea as well as the change in the anterior chamber depth, it seems to be very less, showing an anterior chamber crowding. So redness of the eye.
Citing undergraduate.
Mature cataract, angle closure glaucoma.
Very good.
Yes, ocular trio MDMC, got it right. Yeah, it's a phacomorphic glaucoma. So,
MDMC na Madurai Medical College.
அப்படிதான் நினைக்கிறேன் சார்.
நிறைய பேர் MMC they get confused. No, MMC only ஒரே MMC தான். So நான் ஒண்டி தான் அது MMC. Madurai I don't claim MMC for Madurai.
So some people have answered ACG, angle closure glaucoma. Yes, angle closure as primary and secondary. This is a secondary angle closure. It is due to the lens.
It's not SCAG. Someone is saying SCAG. Terminology wrong. Secondary SACG, secondary angle closure glaucoma.
ஆமா சார். ACG அப்படியே சேஃபா சொல்லிட்டாங்க சார். So SACG ன்னு சொல்லலாம், secondary angle closure due to lens induced.
UG பிரச்சனை. நம்மலாம் UG இருக்கும்போது எப்படி இருந்தோம் அதே மாதிரி தானே, விட்டுரு பரவாயில்ல.
அதனால தான் ஃபர்ஸ்ட் சைடுல போட்டேன் சார் நான். பென்ட்ரோ ஸ்டெப்ஸ்னு போட்டேன் நான். இதுக்கு அவ்வளவுதான், எங்க ஆரம்பிச்சோமோ அங்கேயே தான் இருக்கு அப்படின்னு.
Even worse. Glaucoma na kilo எவ்வளவுன்னு கேட்பேன் நான் UGல.
சார் நானும் அதே ஸ்கூல் தான் சார்.
Okay.
So this is the last picture. I think we wind up with this glaucoma session. So unilateral presentation, that's my clue here, because I didn't give the other eye. This is other eye is perfectly normal. Take for example the left eye is normal. This is the right eye picture showing this kind of a clinical picture. So what will be your first provisional diagnosis that you would want to say? One eye is perfectly normal. Floppy iris, no. Trauma kadayadu. Look at the iris patterns. That will be one of my clue. Iris patterns paranga eppadi irukku.
Uveitis.
Uveitis, yeah, it could be told as one of the differentials where uveitis can occur for. Got it right. Nimha Arif.
Yeah, someone got it right. Yeah,
okay, great. So that's called the eye syndrome. Yeah. So what happens is when you have this condition bilateral, it occurs predominantly in Axenfeld-Rieger syndrome. So it's like AR-AD. I keep it like that. Axenfeld-Rieger is always autosomal dominant, AR-AD, and it is bilateral. But when it's unilateral, it is, and you can see the iris patterns here. There are a lot of iris atrophies. So that is the clue that this is not uveitis, but rather it moves in terms of an eye syndrome. But uveitis also, yeah, you can say it as a provisional diagnosis.
With your permission, Prasanna. So the person who chatted, right? Dr. Neema Arif. Okay, Neema Arif, your thing is right. Kudos, congratulations, but very good diagnosis. But I would say IC put it in capital letters because in small letters, yeah, correct. In small letters, it means something else. So in caps.
Yeah, correct.
So it's an abbreviation.
Okay, sir. Okay, sir.
I think I got it right, sir.
College level, Nihima. You're from which college?
From Stanley Medical College, sir, Chennai.
Stanley, wow, very good, man. Good.
Okay. Actually, the Peters anomaly also I was sure, sir, but I couldn't put it in chat.
Good effort, but
Peters, yeah, Peters. Okay.
Good that you knew it.
I see caps. I will go back to my college days.
Okay, sir.
And one more thing for the PGs and UGs, ICE is an expansion of iridocorneal endothelial syndrome.
Endothelial syndrome, okay.
Yeah, sorry for using short forms.
Good.
So good, very good. So
finally,
I would like to thank my mentor who has given me this enormous knowledge on glaucoma. Without him, I think I would have not been able to do it. And I hope, like in the movie Inception, where they end up with a climax where the top neither falls nor spins, I have not confused you guys, and I have given you a clear picture on this inceptive emerging trends in glaucoma with a case-based approach. So I think it will benefit you in your, be it an undergraduate or a postgraduate. I hope you will be able to take the skeleton of what I have given and bind on to the next level. Thank you, Parthiban sir, for this wonderful opportunity. I really cherish it. Thank you once again, sir.
Wow, Prasanna, very good, man. Kudos to you. Like a comprehensive glaucoma. I don't know if anyone else can put glaucoma in such a small nutshell. I don't know. It's a huge this thing and excellent slides. I really do appreciate your effort in picking up the right slides and very informative, excellent choice of slides. Good. You have all the attributes of a good teacher, Prasanna.
Thank you, sir.
You're wasting your time at Mahatma.
Sir, part time sir.
You belong in a medical college, man. Teaching okay. No, seriously, I'm talking like it's this thing to you. Credit to you, like you have all the makings of a good teacher. So good. Congratulations.
Thank you,
Prasanna. Thank you for all the effort.
Thank you, sir. Thank you.
On behalf of all the students, thank you so much. Yeah, thanks.
Thank you, sir.
Next on to the most dynamic and ever smart, always ever smart looking Vaishali, young and dynamic, energetic. Okay. She is currently working in the Department of Cataract Refractive Surgery at Mahatma. Gold medalist, family of gold medalists. The medal Amma vera nariya gold vechikkranga, neenga vera gold medal vechikkreenga. So it's a family of gold. It's a golden family. Gold medalist in MS Ophthalmology, recipient of Academic Achievement Award, SBB University. And she's an excellent speaker. I know it right from my younger days. So excellent speaker. Now breaking a lot of ground at various national and international forums. Presenting to you, Shruti Vaishali Ramesh. The stage is yours, Shruti.
Thank you so much, sir. So I would like to thank Parthiban sir and the Oculofest team for giving me this opportunity to once again be a part of this wonderful academic forum, that too to be presenting among such prolific teachers like Vijayaragam sir and Vijay sir, whom I have been a student of them. I don't know if they'll recognize, but most of the PG update programs and all, we have listened to their lectures only and kind of helped us achieve this gold medal achievement. So I think already everyone would be very much, wiser in their knowledge on glaucoma by now, since Dr. Prasanna has covered it from A to Z. So it should be very useful for the postgraduates as well as undergraduates. My topic would be about cataract. So I think as Vijay sir was saying, see, cataract is the bread and butter for any ophthalmologist. Whatever be maybe your super specialty after you finish ophthalm, cataract will be the bread and butter. So we are going to be promising the patients really good post-op outcomes. It is almost, it's kind of stepped into the podium of refractive surgery. The era that we are presiding in now is cataract is a refractive surgery. So how do we avoid any cataract catastrophes? It will be in a kind of practical point of view, nothing too deep or complicated. So what do we do before, during and after cataract? Just a few case scenarios. So the first thing I would say is UG or PG, learn how to assess the pupil reaction. Most of the time I see that there is some difficulty when, they have a difficulty in using the torchlight to examine the pupillary reaction. It is very important because we need to rule out a relative afferent pupillary defect, which is the key point for assessing the outcome of any surgery, be it cataract. So if you have an RAPD, then you know that the patient is having an optic neuropathy, which means that their visual prognosis is going to be poor. Again, this all falls under your visual prognosis, your ethical as well as your medical legal aspect, which Vijay sir had covered. So know how to elicit a pupillary reaction, be it a consensual, a direct or a consensual light reflex. So know how to do that. Know what is an RAPD. So RAPD's other name is known as the Marcus gun pupil. So the PGs especially know how to do a swinging flashlight test. So that's how you elicit an RAPD. And one important thing, what is perception of light and projection of rays? See, in our Indian scenario, the patient doesn't present to us in a cataract where the visual acuity is 612 or 624. Especially in the government hospitals, we would be seeing all of them presenting with a mature cataract, hyper mature brown cataracts, and they are going to have very bad visual acuities. So basic step to identify the visual prognosis would be the perception of light and projection of rays. Perception of light, pretty simple. You're just going to shine the torchlight in their eye. If they perceive the light, it's a yes. If not, it's a no. If in a no PLI, you know that even if you do a cataract surgery, the patient is not going to recover at all. Then we have the projection of rays. So this is how you depict the projection of rays. What you do, you ask the patient to cover one eye with the palm of their hand and then ask the patient to look straight. Always UG students, projection of rays is a very important practical step. The examiners are going to ask you to demonstrate that, and you need to document it in your case sheet. So projection of rays in the 4 quadrants, which is the superior, inferior, temporal, and nasal. You're going to project the torchlight in each quadrant and ask the patient from which direction the light is coming from. So if the patient is able to see the rays coming into the superior quadrant, you put a plus in the superior. If it's coming into the temporal, you put a plus temporally. And the nasal also, if they can see, put a plus nasally, and inferiorly also put a plus. So this means the projection of rays is accurate. But in some, take another condition. What if you're shining the light in the superior quadrant and the patient is not able to perceive it? You put a minus. So that means the patient is not able to perceive the light superiorly. Such conditions is mainly seen in cases of RD. You have mature cataract, you're not able to see the fundus, and then you do projection of rays. You find out that it is inaccurate in certain quadrants. It could be an RD, it could be an advanced glaucomatous cupping where there is an entire arcuate defect in one hemisphere. So perception of light and projection of rays, though very simple, these are going to give you a gross visual outcome. And then coming to the slit lamp evaluation. So what we always talk about the endothelial cell count. So initial days in the cases of SICS and ECC, endothelial cell counts didn't make much of a difference. But when we were stepping into the the podium of phacoemulsification, the main problem which was faced by almost many of the surgeons would be a decompensated cornea, because there will be complete loss of the endothelium, and no matter how good a surgery you do, post-operatively the cornea is never going to recover. So what you do, a simple specular reflection, in a high magnification in the slit lamp, if you can place the aiming beam and the slit and the eyepiece at a 60-degree angle, you can see the endothelium. It will give you a gross anatomy of the endothelium. So here you can actually see certain dark regions in the white reflection. So these are corneal guttes, which basically means that the patient is having some sort of endothelial dystrophy. So this is where you need to be very, aware of what you need to do to prevent corneal decompensation. And now, as I think with the technology available at hand, always do a specular microscopy. So this is a gross anatomy, but with specular microscopy, you can actually get the count of cells. So what we say is less than 1,500 cells per millimeter cube. That means that the patient can go into a decompensation post-operatively if you're going to go ahead with the phacoemulsification. So appropriate safety precautions needs to be taken. And in this, you can actually study the morphology of the cell. A term that we use for endothelial cells is the hexagonality. So it is an hexagon. And if you need to see how it is all equal throughout. Is there any dark areas in between? Is there any pleomorphism or polymegathism, which means the enlargement of cells? So those are all indications of poor endothelial health. So then we have a very basic thing for postgraduates as well as undergraduate, when you're going to tell about the type of cataract and the grade of cataract, go for the lens opacification classification system 3. This is the most advanced classification methodology. So you need to classify the nuclear cataract separately, the cortical cataract separately, and the posterior subcapsular component separately. It is not a whole thing. So this is the grading pattern for nuclear cataract. You based on the opacity as well as color, it is NO and NC. For the cortical, it is the C. For posterior subcapsular, it is the P. So based on the grade, it can vary from 1 to 6. So the different types now. So basically, immature senile cataract, we know about that. But what are the the clinically important ones? So first image here, what I'm showing does look like a Mickey Mouse, right? It's actually a very notorious posterior polar cataract. So posterior polar cataract, why it is very dangerous is it looks, sorry. So I'm so sorry, just a minute. So yeah, posterior polar cataracts, what happens is that the main issue with this is that the posterior capsule is very weak in such cases. And you can, what happens the moment you start doing your surgery without knowing there will be a posterior capsule rent and the nucleus is just going to drop. So we need to assess it preoperatively, know what sort of cataract it is so that you can avoid such catastrophes from happening. And you see something like this, flower-shaped rosette cataract. We know that we see this in trauma. So what other things do you see in trauma? You need to assess the periphery of the retina, see for any breaks or tears, see for any dialysis, see for any zonular weakness, see if the optic nerve is healthy, the macula. So all this assessment should occur comprehensively for a successful cataract outcome. The third picture which I'm showing is a nice big zonular dehiscence. So this was one patient he was actually a very high myope. And when we dilated him, this is what we could see. So in that cases, you need to plan for a ZD. You need to have a proper setup, a capsular tension ring or a Sionis ring, or are you going to do a complete lensectomy and place a secondary IOL? So that's how we plan. Because, so in that aspect, pupil is very important. You need to dilate the pupil and only then evaluate a cataract. Because if you know preoperatively the pupil is not going to dilate, then again, that is another extra step of pupil expanders which you have to go into. Then we have the inflammatory part in the anterior chamber. So this was actually a patient. She presented like this to us. She told, I come for a cataract surgery. So when I saw that, you can see this is a complete iris Brombe with the seclusio-pupillary membrane. So then when the history, I asked her, what had happened. She told she used to have recurrent red eyes and slowly, gradually her vision started dropping. But now she doesn't have any pain. So this eye has actually started going into phthisis. Her IOP was very low. And when we did a B scan, there were a lot of vitreous membranes and she only had PL, her PR was inaccurate. So what we suggested to her, we do not touch this eye currently. First, let us assess the cataract in the other eye, and if that is significant, go ahead for the surgery in that eye. So this is where the medical legal aspect is very important. Only and only when you know the clinical findings and how to go about, can you avoid any such catastrophes. And now this is an active inflammation. The picture to the left is an active inflammation. You can see the keratic precipitates on the cornea. There is cells, there is flare. Never do cataract surgery when there is an active inflammation in the eye. You need to first treat the inflammation, have a peroperative steroid cover, at least have a quiet eye for minimum of 3 months before you progress towards cataract. Because in an inflamed eye, if you do cataract surgery, it is just going to increase the inflammation and it is going to be very difficult to control it post-operatively. So another thing, now I'm pretty sure most of your friends would have also undergone refractive surgery. So sometimes if you see the patient will not reveal that history to us. So do a thorough evaluation from limbus to limbus. The corneal evaluation is very important. And when you see that, you can see here, there is a slight difference in the tone of the cornea, the circular difference where I'm showing the arrow. The patient had a previous refractive surgery. When I asked the history, when I prodded into the history, that's when it came out. What is the problem with this cases is that we all know the SRKP formula. I'm pretty sure you would have all known that name, but we cannot apply that formula for cases with post-refractive surgery. And you need to do a corneal topography. You need to map out the cornea before you can go ahead for a cataract surgery. So a small snippet for you to remember, a PG or UG, if you're having a case of post-refractive surgery for a cataract, always go ahead with these two IOL formulas. Remember these names, which is the Barrett Universal 2 and the Hill RBF. Hill RBF is actually an IOL formula which is under the principle of artificial intelligence. So now that is what is being developed. So finally, coming into the fundus evaluation, I'm pretty sure that the number of diabetics that we come across, for cataract surgery, almost 60 to 70% of the patients are diabetics, and at least a minimum of 20 to 30% have diabetic retinopathy. So when you're doing cataract surgery for diabetic retinopathy patients, there are a few things that you need to look for. Say the patient has a dense vitreous hemorrhage like this, and you see that the cataract is not actually significant. It's just, a nuclear sclerosis grade 2 and very small PSCC. The vision loss is mainly due to vitreous hemorrhage. We should not do a cataract surgery in that case. And as I was saying, the projection of rays, this is where it comes into play. You can see that there is a tractional retinal detachment. It is involving the macula. So again, for such a case, cataract surgery will not be visually significant. So do a projection of rays, check this, do a B scan. And first, if the fundus view is pretty good, we have to treat the fundus pathology first, do a retina surgery for the RB, and then and only then, when the cataract is significant, do we go ahead with cataract surgery. And then the final thing is the rhegmatogenous retinal detachment. Here you can see how the folds of retina are coming from the periphery, and it is involving the macula. So in this case, when you're typically projecting the light into the superior and the temporal quadrant, the patient will not be able to perceive it. So keep these things in mind when you're evaluating the patient. And something that glaucoma, which is already covered by Dr. Prasanna beautifully, look for glaucoma. See, glaucoma, I think the term that we use for, whenever we give awareness lectures is that it is a silent killer. You don't know it is there because I hope this picture is clear. What you can see here is that the papillomacular bundle is still not affected. This is an advanced glaucomatous cupping. The papillomacular bundle is still not affected, and the only affected region is the superior retinal nerve fiber layer, arcuate region here, and the inferior arcuate region. So the patient, you have any cataract patient, look for glaucoma. Because if glaucoma is there and there is a raised intraocular pressure, you need to plan whether you're going to do a combined surgery, that is cataract with trabeculectomy, or are you going to just do a cataract first, control the IOP medically, and then if required, go for a secondary surgery. So there are multiple things you need to look into. And especially if there is a raised intraocular pressure preoperatively, we need to reduce the IOP before you do cataract surgery, because it will end up with an expulsive choroidal hemorrhage. I'm pretty sure that, in the previous earlier days, when that was the days of ECCE, most of the surgeons would have at least experienced expulsive choroidal hemorrhage. You cannot do anything for those cases. You're completely losing the eye. So now we have the modality of a very, formed closed chamber techniques and everything. The only risk factor here is the high IOP. Never take a surgery of high IOP for cataract surgery before controlling the intraocular pressure. So coming to the B scan. So say you have a mature cataract, you have done the projection of rays, the perception of light, everything is normal. Then you want to always do an ultrasound B scan for those cases to see any gross pathology in the posterior segment. So over here is a mature cataract where we did the B scan. I can see some sort of attachment from the optic nerve head, but what I detect here is that there is really good after movement. Every time the patient moves, there is fluctuation of that membrane, this hyperechoic membrane. So that means this is just a posterior vitreous detachment. It happens in almost most of the old age people, so you don't need to worry about that. You need to differentiate this from a retinal detachment. Now in this video, if you can see that this is actually a retinal detachment, there is no after movements. You can see that there is hyperechoic lesions here suggestive of vitreous hemorrhage, and this is a nice RD attached to the optic nerve head. So again, in this case, you need to be very safe. You need to, if it's a mature cataract, yes, we need to do a surgery and then go to inform the patient that you might require a secondary surgery. So those are the things that we need to keep in mind, because if you, without doing this, if we can just promise the patient saying, okay, you do a cataract surgery, your vision is going to improve, then that's not going to sit well post-operatively. And then, as I was saying, the posterior polar cataract, I said that we need to look at the posterior capsule. If it's a very clear lens and just a posterior polar component, you need not worry. With the slit lamp evaluation, you can check the integrity of posterior capsule. But mature cataracts might also have a posterior polar component. In that case, you should do a B scan to check the integrity of the posterior capsule. So that's how you evaluate. And then finally, this was again a case of uncontrolled diabetes for almost 5 to 6 years. She came for cataract surgery, and you can see this hyperechoic lesions in the vitreous, suggestive of vitreous hemorrhage. So we needed to go ahead to the surgery with the guarded visual prognosis, saying that she might require a core vitrectomy later on. So those are the things that we need to be aware of. Then comes the biometry part. In the very much earlier days, biometry did not play a very important role. We just measure the axial length keratometry, or in a theoretical sense, we need to place the IOL. But then, as I was saying, cataract surgery is now a refractive surgery. You cannot even afford to, leave the patient say 6'9" or 6'9" parts. The patient all demands 6'6" or even better. So that's where the biometry part comes into play. So it is mainly of three types. This all comes together to play the biometry, which is the keratometry, which is the curvature of the cornea, axial length, we all know the length of the eyeball, and then the IOL formula. These three go hand in hand. So immersion biometry is something that is practiced almost everywhere nowadays. You guys would have all seen this spikes when you're working up the cataract patient. I'm pretty sure you had all seen that. And then we have the keratometry workup. You need to do a keratometry. What is the K1? What is the K2? So based on that is where you can place the give the data into the IOL formula, and it's going to give you an IOL power. So in sense of the advancement that is going on now, almost many surgeons are stepping into the podium of optical biometry. PGs as well as UGs, you need to know the basic name of the instrument and what is the principle behind it. So the IOL master, what you need to remember is that it is a partial coherence interferometry, and the lens star is low coherence interferometry. So what you need to know here in these is that this machine, they give you a keratometry as well as axial length, and they also have the IOL formulas incorporated in that. So they give you the best IOL power to have a emmetropic eye postoperatively. And their standard deviations are like really good, and the predicted error is minimal as possible. So some things that, Vijay sir was saying, endophthalmitis, it is given in the book. Yes, it can happen to anyone. But now, why has it reduced? I would say that the percentage has reduced tremendously in the previous decade. What is the reason? Basically, is the preparation. So we know that preoperatively, there are multiple things to prepare. We tell the patient, wash your face, we trim the eyelashes, or, we tell them take a hair bath, cut off your nails. We give them preoperatively antibiotics. But all those aside, the main component is this 10% povidone iodine for the skin and 5% povidone iodine for the conjunctiva. This is, again, I think these are asked very frequently in NEET as well as for PG exams. So when we do this, the risk of endophthalmitis has reduced like anything. Then coming to the pupil part. So now intraoperatively, so we all know the basic stuff, the wound construction, what can happen and what not. But I was saying, if the pupil doesn't expand, if there is no good view of the cataract, you cannot do a cataract surgery. So basic thing we can do is a sphincterotomy. But now people actually want a round pupil postoperatively. They don't settle for anything less. I don't want my pupil to look irregular. So cosmetic aspect also, they are demanding that. So what we need to do is we should go for pupil expanders. So here we had a case of phacomorphic glaucoma. The pupil was not dilating beyond 3 mm. So we went ahead and used the iris hooks to actually dilate it to up to a minimum of 6 mm so that we can go ahead with phacoemulsification. So you can see the posterior synechia here. So it's basically holding the pupil in place and not allowing it to dilate, even if with all the mydriatics that we could use. So we had to release these posterior synechia also so that the pupil will give way. So once you put in this 4 iris hooks, you can see that there is a good view of the cataract. So we can go ahead with the comfortable surgery. Should never go ahead without view of the cataract. We always say this to all the surgeons. So the other pupil expanders is the Malugian ring, and now in India we have the B-hex ring. So there are many things there. So learn the names of them and where it is useful. And something called as the Argentinian flag sign. Every cataract surgeon has experienced this. As I said, in India, which is a developing country, most patients present to us with a hypermature cataract or nice intumescent bulky lens where the intralenticular pressure is very high. So Argentinian flag is something like this. You have the blue in the periphery and the white in the center. So we all know we stain the capsule using tryphan blue. And what happens is the moment you make a nick to make a capsulotomy, it just gives way both sides. So you can see a blue, a white, and a blue. So this is your Argentinian flag sign. So when this happens, the surgeon needs to know how to avoid this and how to manage this, because sometimes this tear can spread to the posterior pole and cause a nucleus drop. So that's where we need to be very vigilant and prevent this from happening, or even if this happens, we need to manage it. And then, as I was saying, the subluxated cataracts, or if you experience a zonular dialysis intraoperatively, we should know what instruments and what technique that you need to use. So we have the capsular tension ring. So only use the CTRs if the dialysis is less than 3 clock hours. And if it's between 3 to 7 clock hours, go for a Sionis ring. And you can see these eyelets here. These eyelets are for scleral fixation, so that, over time, there isn't more subluxation. And the best of all is the Ahmed segment. You have a very big ZD. You can place 2 segments opposite sides and fix it to the sclera. So PGs also, these are very important. Subluxated cataract is very, very important. It can come as an essay. So know all the different modalities through which you can manage that. And something I think all cataract surgeons again can sympathize is that we all learn by this thing happening to us, which is the posterior capsular rent. Invariably, every surgeon goes through that. So you can see almost everything has gone well. The nucleus management is almost done, and that you can see a nice big posterior capsule rent, a big parallel rent. So this is the thing. This has happened now, and every surgeon will almost experience this a few times in their lifetime. And this was actually a case of posterior polar cataract. So it already had a weak PC. So we need to know how to manage it. Okay, this has happened. How do we manage it? We can't just leave this patient. We can't say, okay, PCR has happened, I can't do anything. We still need to give this patient a good outcome, which we had promised them. So in that aspect only, PCR happens, it can happen. So, you need to use a dispersive viscoelastic agent, tamponade the vitreous, prevent further vitreous loss, or you can do a nice vitrectomy, stain the vitreous. In this case, there wasn't any vitreous loss, so we were able to place the intraocular lens in the bag. This is actually a multifocal lens, and the patient is very happy post-operatively. So as I was saying, PCR. Another thing that can happen with PCR is that this scenario, you try to place the lens and it just drops into the vitreous. So in such scenarios, again, you can't go fishing for the IOL once it has gone beyond the posterior capsular plane, we cannot go fishing for it. So such cases, we need to close the eye and refer it to a vitreoretinal surgeon. That's the only thing you will do. Whatever vitreous is there in the AC, you can stain it with the, preservative-free or triamcinolone, and then do a vitrectomy, and you can just close the eye. That's all you do. So PCRs can lead to IOL drop, entire nucleus drop, or just a fragment of the nucleus. But everything needs to be managed very properly. So leave the intraoperative side. Now we have something, I think many of the patients will come. Initially 1 month, it was all very good. I could see very clearly, why is my vision dropping now? This especially happens when you're placing a rigid IOL, the PMMA lenses. So the after cataract. So there are 3 types. Theoretically, we all know that the Elschnig pearls, the Sommerring's ring, and the fibrous one. Elschnig pearls is the most common one. You can see the posterior capsule opacification. Then we have the Sommerring's ring and the fibrous one. Very easy to treat. You just need to do a ND-YAG capsulotomy. You just open it up. Now we know about the posterior capsule opacification. Some cases, PXF, pseudo-exfoliation, retinitis pigmentosa. What happens is anterior capsular phimosis happens. So the anterior capsule opening has completely closed off. The patient had a 6/6 vision post-operatively. After 3 months, she's presenting with 1/60 vision. So the trick here is that if in the initial stages you see the anterior capsule constricting, we can do radial capsulotomies. But if the patient presents so late, you need to do a membranectomy. So that's what we went ahead with for this patient. So we surgically made an opening. So using meticulous planning, because this again, she was a PXF patient and she had already undergone, we placed the CTR and then only placed the IOL. She had a zonular dehiscence. So we had to do the surgery very meticulously and give a clear opening. And the anterior capsular phimosis has a tendency to recur. If you opening is again very small, it can recur. So give a very clear opening, and post-operatively, again, she was very happy with a clear central opening. So then the Irwin gas syndrome. So what is that? The other term for that is the cystoid macular edema, which occurs post-operatively after 6 to 7 weeks of uneventful cataract surgery. So in this image, this patient, again, she was very happy post-operatively, and 1 month later, she's presenting that all the lines are very wavy and the images are looking very small in the center. Something is wrong. I'm a tailor and I'm not able to do the cutting properly, the measurement properly. Never dismiss that. Overall it will look normal, but when you just, do a very meticulous workup, you'll realize that there is some gray spaces in the macula, gray cystic spaces. So this is a typical cystoid macular edema. And when you do an optical coherence tomography for the patient, you will see the cystic spaces in the macula. So you need to treat them accordingly, give them posterior subtenon injection of steroids to avoid such cases, high risk cases with the previous uveitis. You can even start them on NSAIDs, Nepafinac or Bromfenac, post-operatively immediately. And the dreaded thing, endophthalmitis. So when this happens, it's not an if. When this happens, you need to know the cocktail of injection that you need to give to save the eye. So the two things can go. You can do a vitreous tap and give an intravitreal injection, or you can do a core vitrectomy and give the intravitreal injection of vancomycin and ceftazidime. This is the first line. The thing with amikacin and gentamicin, they have high macular toxicity. So the moment you give the injection, everything might look good, but the patient vision will just gradually drop and the retina will go for ischemic changes. So always go for vancomycin and ceftazidime first. And if there is very poor vision, less than hand movements, do a core vitrectomy. And if you have ruled out fungal etiology, you can even give a small intravitreal injection of dexamethasone. So now coming, what happens if we leave the patient aphakic? Sometimes, the PCR might be very big. We might need to leave it aphakic. You need to always do a peripheral iridotomy because this can happen. The vitreous can prolapse into the AC and cause a pupillary block glaucoma. So you cannot allow that. Always do a peripheral iridotomy. And this is a very late post-op complication. PXF, again, pseudo-exfoliation. Patient was 10 years back, she had surgery. Now she came with diplopia and reduced vision. When we examined her, we can see that the IOL has subluxated. It's not dislocated, it's subluxated along with the back. So for such cases, you need to do a secondary IOL implantation. So there we have the iris claw and the scleral fixated IOLs. These are all, again, very easy and advanced procedures which have now arisen. So you can, again, give the patient what you had promised, good visual recovery post-operatively. Simple techniques. The initial days, I think we would have left the patient aphakic, given them aphakic glasses, or nowadays we even do anterior chamber intraocular lens implantation. But the risk with anterior chamber intraocular lens implantation is there is always a risk of UGH syndrome, uveitis glaucoma hyphema syndrome. You need to look out for that. In secondary IOL implantation, always never forget to do a peripheral iridotomy to prevent pupillary block glaucomas. We have the iris claw, and we even have the scleral fixated IOLs. It can be sutured or it can also be glued. So all the techniques are available. And one of the complications which I mentioned very early on was the bullous keratopathy. If the endothelial cell count is lost during cataract surgery, which reduces to less than 500, then the patient is going to lose the cornea to bullous keratopathy. And the only way to manage that would be a corneal transplant. Very early on days, it was penetrating keratoplasty, but now these patients have a very good outcome with decimate stripping automated endothelial keratoplasty or just a decimate membrane endothelial keratoplasty. You don't need a full thickness keratoplasty for these cases. So I think I saw this meme in the Oculofest site in Instagram. So I think what the students are saying is now we always have the idea that we're going to always get a glaucoma or cataract case. Entropia and corneal ulcer, where is it going to come from? Who's going to ask? So after I think Dr. Prasanna and my presentation, they're all going to be like this. Okay, cataract glaucoma case for Viva, we'll just handle that. Hopefully that's how the outcome is. Thank you, sir.
Vaishali, thank you so much, Vaishali. Shruti, it really amazes me. I don't know how you people can do these things in such a nutshell. It really amazing. I don't know. Seriously, it requires a lot of skill to put a lot of things into one small nutshell and take home the message, for the undergraduates.
Thank you, sir. Thank you, sir.
Beautifully presented. Excellent, lovely presentation, lovely collection of slides. And very informative and very, very informative, and highlighting money have to be really much real necessity for the undergraduates. So kudos to you. Beautiful.
I think sir got muted.
Sorry, chip of the old block. Highlighted. Chip of the old block. Really, this thing praiseworthy, excellent. Thank you so much.
Thank you, sir. Thank you, sir.
Thanks. And finally, on to the last speaker, but not the least, the man himself, Ramesh. I think needs no introduction for people in Trichy, one of the leading ophthalmologists in Trichy, the big man himself from Mahatma Eye Hospital. Munadi vandavanga ella chippa the old block, but this is the block himself. So Ramesh has been a great friend of mine right through the years, an ardent support of Oculofest. I don't know, and I love meeting you. It really amazes me how this man has all the. He has a very big heart for academics. I would say, like now, again, I repeat this again in this forum also. You can be a great practitioner, a private practitioner, earning a lot of money and making really big in ophthalmology, but you really need to have a huge heart to teach your students. And your thing towards academics, your contribution towards academics, Ramesh, has been excellent. And you've been a great support for me and my students here in KAPV Govt Medical College. Really very happy that you're a part of Oculofest every year in and year out. Thank you so much for all your your enthusiasm, your great support for the Oculofest. Thank you, Ramesh. Thank you. And the stage is yours.
Thank you, Parthiban. Thank you, Parthiban. Can you hear my voice is audible?
Yeah, audible.
Parthiban? Parthiban?
Yeah,
voice is fine?
Yeah, fine.
My voice is fine?
Yeah, voice is fine, yeah.
Yeah. And coming to the last of the confusions, like I feel like way back when Parthiban and myself, we were all undergraduates, ophthalmology was very simple. Not much of subspecialties to make more confusions, but still pretty very developed and interesting specialty. And just try to share some sort of practical things which may influence undergraduates and postgraduates. Like one of my professor used to say, eye is one organ in the body that has got some 60% representation in the brain, and 6 cranial nerves have a role in ocular movements, corneal sensation, lid closure. So it's a very unique organ with a lot of complex ocular motility issues. And we all know about the ocular movements, elevation, depression, extroversions, leverversions, and all the 9 gazes. And we know that some muscles extort the eye and some intort. There is always a synonym like synrad. All the superiors are intortus, superior oblique and superior rectus, and all the recti as adductus. So these are all simple ways we can remember this way to remember this ocular movements. Not much to be worried about what really this multiple complex movement is. But there are videos to show ocular motilities it's all there in the YouTubes, like a lot of complex ocular insertions in various angles, how each eye moves and all. I don't want to go much into the detail, but these are the 9 cardinal gazes in which we need to know which muscle acts like. So it's all very much in the textbooks. And as you know, this binocular single vision, that's what keeps the whole human race on top of the animal kingdom. That what we are all looking at when we talk about strabismus is how to keep the eyes aligned so that we have a very good human being have a very good binocular single vision. So there are, as you know, 4 recti and 2 oblique muscles in each eye. They all act in synchrony, and there are agonist and antagonist muscle. A very simple example is like if you're looking to the right, then you know that your right lateral rectus and left medial rectus is acting together. So they need to have a synchronized innervations. At the same time, when the 2 muscles, like for example, synergist action, like superior rectus and inferior oblique, they have to act in a synchronized way for the eye to move in the right directions. These are all very much textbook like. So yoke muscles, a pair of muscles, one in each eye producing the conjugate movements. And antagonist muscle, what they do. And when the lateral rectus acts, the medial rectus has to relax. So there should be a reciprocal minimal innervational effect on this eye so that this relaxes to make the other eye move. So this is basically this Sherrington's law, where there's increased innervation to a given extraocular muscle. For in this case, a left lateral rectus. At the same time, the left middle rectus gets a decreased innervation, reciprocal. How this synchrony is maintained by starting from the visual stimulus to the ocular muscles, nerve supply, cranial nerves, central nuclei. This whole synchrony is all the ocular motility and all the Heyrich's law is the simple where the yoke muscles act in synchrony. Many times, like unlike cataract, glaucoma, retinal diseases, herein this is the one area which is more of medicine. We have a lot of neuro-ophthalmology involved. We have to talk more to the parents about the complaints, age of onset. Everything will give a clue regarding what type of strabismus you are facing, type of deviation. It may vary in different cases. That may give an idea regarding is it a myogenic, restrictive strabismus, a paratic. Acute onset can be a paratic, or it could be inflammatory response resulting in a restrictive strabismus. Developmental history regarding the multiple developmental anomaly. As I said, brain vision constitutes 60%, starting from the optic nerve to the optic radiations. So much of representation is there for the vision pathway. And treatment history when it comes to managing a lazy eye and amblyopia is essential. Basic essential ophthalmic tools required in evaluating a squint. Refraction set, everyone should be aware of it. It's the very basis of ophthalmology, refraction. And in a kid, probably we may have to use a streak retinoscope. If you're going to become a qualified ophthalmologist or a postgraduate, streak retinoscope is the way to go ahead. Have this lens bar so that in children, very difficult to put in individual lenses to have a look at them. They have a lot of toys because like vision testing, unlike in adults using a silence chart is not possible. So we have various methodologies like the vanishing optotype principle, like the Cardiff card. The gray chart is the Cardiff card. The white lines become thinner and they have equivalent channel represented behind. And this is a preferential looking method. The child will look at the preferential gratings. We all know about it. And a lot of ways we can assess the children's vision. Just patch one eye to see whether the patient is able to have a good vision. This means that the child's left eye vision is good. That's why it's not doing much of crying or attempting to do anything nonsense. And the simple cake decoration, we put it over the cakes. You can see that in the palm of the mother. If the child picks, you can have it in your pocket, no OPD basis. A simple evaluation. Child is able to pick it up and put it on its mouth. It means the child is having at least a vision of 6/24. That's a very beautiful information of vision we get such a small child. And refraction is an art. I know like Dr. Parthiban and myself, when we were ophthalmologists, we have to do our own refraction. But now a lot of changes is happening in our specialty. The technical expertise is taken over by optometrists, but still not to do a refraction to understand the basis. And to do in a child is an art. We can talk a lot about it, but it's very, very important part of the strabismus management. And coming to the motor test, head posture. When the child comes with, whenever we go into medicine OPD, also says, see the way the patient walks in. From the gait itself, we can pick up a lot of finding regarding what sort of problem he has got. Like that child, how the way it keeps the head, because a lot of fusional anomalies are going to happen in this child. So depending upon the way they keep their head, they're trying to avoid one particular gaze. That means they're avoiding some sort of double vision or there is some sort of restriction. So that gives us a clue regarding to evaluation. It could be due to a paratic squint. So the reason we see in a medical OPD or in ophthalmic OPD, when they send a case for a 6th nerve or a 3rd nerve evaluation, they come with acute movement restriction. And there are some patterns in squint. I'm not going to elaborate. Nystagmus you would have seen will have a face turn to get into the null point. And 1/8 patients do observe a face turn. And gross refractive errors itself can have face turns. And simple torchlight tests, as Prasanna was telling, most of the time we just do a torchlight evaluation as undergrads. Always do a simple torchlight test on all your patients. So you'll pick up a lot of subtle ocular motility or alignment problems. If the light, there is So it's spot on central cornea, we know it's orthophoric. If it's at the pupillary border, 15 degrees. If it's midway between the pupillary border and the limbus, it's 30 degrees. And at the limbus, it is 45 degrees. This gives us a rough idea of how much of degree of squint we have. So when we want to do a surgical correction into 2 prism, 1 degree is 2 prism diopters. We calculate into prism diopters and then measure the muscles and work on the muscles to align the eyes in straight. And most of them is all observation. So do a simple cover test. So this will diagnose hidden squint, manifest tropias, and always the uncovered eye is observed to see what sort of fixation movement is making. If it is coming out from in, then it means that it has been in a deviated position. That's how it denotes whether it's exo, ESO, or a hyper or hypo. Cover uncover test, check the eye under the cover and to detect how much of phoria or hidden squint is there. Phoria is a latent squint or a hidden squint. Manifest is a alternate cover test, measures both phoria and tropia. The purpose of doing an alternate cover is to break the fusion. Fusion is a binocular function. Some children, they come with a history of parents saying child has got a squint, but we may not be able to detect anything. In that case, in an outpatient, just simple put an eye patch or normal iPad and patch, make them wait for a half an hour, 1 hour or 2 hours. Then after some time, when you remove the patch, you see the eye is either deviated out or in. That gives us a clue that we are handling some sort of an intermittent ESO or exotropia. And when we use prism lenses, what we do, the prism cover test is, we place the prisms to measure how much of prism strength is required to neutralize this deviation. So this will give us an idea how much of prism deviation the eye has got, and based on which we start treating the patients. And the Krimke's test is where the prism is placed on the eye, and you can put a torchlight. We can bring the eye to the orthophoric position. The prism strength is given on the base of the prism. That will give us how much of prism we are handling. And the first slide, where you can see an abnormal red reflex on the left eye, it's called a Bruckner's reflex. Bruckner's, B-R-U-C-K-N-E-R''. Sometimes when there is a child, they say there's a squint. Nothing looks very obviously wrong with the eyes. There are ophthalmoscope, 1 arm's length, shine it over the pupil, both eyes. If you see an abnormal red reflection in one eye, that is the eye that is squinting. That gives us a clue that yes, there's a small angle squint in that eye. And as I was telling you about refraction, the most vital part of squint evaluation, fundus examination. If it is a grown-up kid, yes, a direct ophthalmoscope is still a good tool for a kid. But if it is a grown-up child, we can still do a good indirect ophthalmoscopy, or even for an uncooperative child, we need to have just a view of at least the disc and macula. Because most visual pathologies, sensory ESO or exotropia, is going to be a macular pathology. So look for at least a disc anomalies, optic atrophy, hyperplasia, optic disc, macular anomaly like retinoblastoma, macular colobomas, toxoplasma like that. Sometimes a sinister sign where there could be an acute onset squint like this in girl, a midbrain lesion. Don't miss on them. And first section test is just a mention about it, because this we do it in OR to just see if there's any muscle restrictions when we do just before you go on to do a surgery, or in restrictive strabismus when there's a tight muscle, plan accordingly that management. Or sometimes if you may have something like a blowout fracture, a ENT person can send a patient for a follow-up, a sunken eyeball, infraorbital anesthesia, inferior rectus may get trapped in the maxillary floor of orbit fracture. So visual assessment, orthoptic evaluation, cycloplegic refraction using cyclopentolate eye drops, very important in children. Very small toddlers in infant esotropia use atropine ointment 2 times a day, 3 days, and then do a refraction, because we don't want the accommodation to come into play and give a wrong correction. ESO deviation, I just gave a brief overlay about evaluation of a squint. It's an inward squint. It's the commonest we all see comparing to the ESO or exotropia, any type of squints. This is one child with a pre and post surgery. This is a beautiful outcome we can give as children, and we can make them attain a reasonable amount of binocular vision, if not a full binocular vision. And many times we see a pseudo esotropia. Look, children have this sort of that fold over the medial canthus, epicanthal fold, but that may mimic esotropia. But torchlight evaluation, Hirschberg's light reflex, we know that it is a central light reflex, but still do a cycloplegic refraction, assess that there is no refractive error, and then give a final verdict. And I was telling about phoria and tropia. Hidden squint is phoria. Only a breaking a fusion by doing a cover test or patching, it gets revealed. Most of these cases will have hidden refractive errors, which has to be treated, and they usually manifest with fatigue, illness, more presenting during illness or when they are stressed up, not seen commonly. Obvious constant deviations that we can never miss it. That for them, surgery is the ideal treatment protocol. Incontinent is something mostly paralytic or restrictive. Paralytic would have seen in your neuro postings and neuro-ophthalmic postings. 6th nerve and 3rd nerve is the commonest we see, and we do see trochlear nerve pulsing, pausing, closed head injuries, and myogenic could be something like myasthenia, myopathies. Restrictive strabismus is a condition called Duane's, and other, as I was telling you, acute onset. It could be something like some sort of a abscess or some sort of a tumor, secondaries from elsewhere. A lot of things you can think of. And accommodative strabismus is what a pure, most of the time come to the ophthalmology in a pure ophthalmology because high hypermetropia. Most of us don't think of evaluating a child for a refractive error. That's the most commonest thing you should always do in a squint, because simple refractive error treatment in a purely refractive hypermetropic accommodative esotropia will make the eye straight, and you're going to give the the child a good binocular vision. Only if it is otherwise like a partial accommodative, then okay, treat the refractive error, then the residual squint, do a correction, things like that. So most of the time, refraction is a very, very, very important basic evaluation which you need to do it. And when it comes to essential infantile accommodative esotropia, I was just telling you, it can vary depending upon the effort of accommodation taken. And this was a child, both of them are twins. They came with a similar history of intermittent esotropias and high hypermetropic refractive correction. As you see, the alignment has become better. So just a simple refraction is going to treat a condition. No need to even put your scalpel on these patients. Partial accommodative, as I said, partially refractive, partially non-refractive. Non-refractive is surgical correction. Refractive is with the spectacles. And congenital esotropia is the commonest we all face. So mostly at birth, that's what we say. But we all know it takes 3 to 4 months time for all the ocular functions to develop. So usually starts manifesting by 4 to 6 months of age. And they do have a very nice this thing called a cross fixation. They try to use the right eye for the left gaze and left eye for the right gaze. And usually they are not associated with any gross significant refractive error, but they still rule out by doing a cycloplegic refraction. See, they're freely alternating both eyes so that they don't have binocular single vision, but then at least they are not amblyopic or lazy eye in one eye. If there's a preferential fixation for one eye, then the other eye is amblyopic. They'll have to patch the better eye and manage them, then go in for a surgery. Usually these congenital esotropias have a large angle squints. And this is one kid I still remember operating as a 11 months baby. And this is a preoperative photograph and this is a postoperative. And again, these children we tend to undercorrect as surgeons because they have a tendency for an outward drift as they grow older. It's called as consecutive exotropia. And we can give them a very beautiful pre-post alignment. Certainly the cosmetic aspect also matters because as they go into school-going age group, they are tormented by the peer pressures. Like I know a kid who was in a kindergarten was pestering the parent that I'll not go to school. Then after he had his surgery done only, he was happy that his eyes have become all right. We do correct on the muscles. We weaken the middle rectus in a esotropia. We know the middle rectus is overacting. So we weaken it and we strengthen the lateral rectus. The lateral rectus is resected. And a lot of treatment modalities are there. So I don't want to go much into it. Simple patching therapy, patch the better eye so that the worse eye is made to stimulate, vision stimulation is done, and then go in for surgical correction. Differential diagnosis, the commonest will be 6th nerve palsy and Duane's like a restrictive strabismus. And many times accommodative esotropia usually will be able to pick it up some age of around 2 to 3 years. That's an age group the children start using the eyes for near. Till then, they can have a variable ocular alignment. So if it is a intermittent sort of esotropia. So look for accommodated esotropia age group of 2 to 3 years. And if it is anything less, it could be mostly infantile esotropia. Microtropia is one condition, maybe for the post-graduation. Sometimes we may have a eye looks very much aligned, like vision is not improving beyond 624, you'll be breaking your head, you'll be doing a good refraction, everything's normal, no refract error, fundus, macula, everything is healthy, optic nerve is healthy. Sometimes we think, is it a neurological problem? Everything looks fine, but there's a simple, it's called as a 4-prism test where they have a small macular scotoma. So they may have a very small micro deviations. So that's what is called as a microtropia. Sudden onset squints, always be beware of a neuro-ophthalmic problem. So this is one area where you have to take a neurologist's opinion because you may be handling a neuro emergency. And this is one thing which may be rare, but we should never miss, because sensory esotropia due to an pathology in an organelle pathology in the retina or the optic nerve. Most of the times, the standard textbook teaching is when we have a esotropia with a white reflex, look for retinoblastoma, because when it could be rare, but it's one of a eye vision threatening at the same time life threatening. Now, retinoblastoma picked up early can be, the globe can be salvaged, vision can be salvaged to some extent if it is not involving the macula. At least, or else at least we can avoid spread via optic nerve or to the orbital spread can causing secondaries. Should be a very important thing you should have in mind in sensory esotropia. And coming to the not as common, the less common one, exotropia. Exactly similar, only thing is it's just the other way around. It's the lateral lectures that sort of overacts and takes the eye to the divergent side, usually manifests a bit later, 2 to 4 years of age. So management is relatively easier here. Some of them also give an apparent appearance like an exodeviation, high hypermetropic eyes, sometimes ROP children, retinopathy of prematurity now is being very well managed in your department. So, you know, they can have some macular traction, so they can induce some sort of a pseudo exotropia like situation. Same thing like phoria and intermittent exotropia and exotropia. Same pattern how they develop. As the fusion starts becoming weaker, and the good fusion, they have exophoria. Moderate fusion, the phoria sometimes become trophia, becomes a manifest squint in between. And exotropia is a constant squint. And actually similar sort of a committant and incomitant, same, some similar type of classification, all given in classical textbooks. And infantile intermittent exotropia is one thing which we always look for. We can miss in a clinical scenario because the parents will come with a history of squint, but we may not be able to observe anything. I'll just show you a small, I think I have a video of the child. And large angle deviation, they do very well when you do a surgery. And this was a child, as you see the photographs, it looks aligned, but you see the child is made to look at a distant object. Again, when you do a squint evaluation, the basic squint evaluation concept is always have good accommodative targets for near and distance, and always measure squint for both near and distance and with or without correction. It's a very important thing. And in these cases, sometimes the parents come with a complaint saying like that, my child closes the eyes when it sees bright light, only one eye. It's a condition called diplophotophobia. May not be asked in undergraduates, but postgraduates, you may be asked this thing. As the phoria breaks into atropia, they have a confusion, diplopia, that they tend to close one eye. That is a sign that the eye is drifting towards exodeviation. Phoria is becoming atropia. That's called as a diplophotophobia. This boy is a boy. I just one of the pretty old videos, easily 20 years back. I'm just asking you to focus at the pen, and after some time, I think after breaking the fusion and ask him to look at the distance, you can just see the eye starts drifting. This will be more obvious when they are sort of disturbed, when they are tired, weak. That's a typical history the parents say. ரொம்ப ஒரு மாதிரி சோர்வா இருக்கும்போது கண்ணு மாறுகனாது, காய்ச்சல் வந்துச்சுன்னா கண்ணு மாறுகன்னு தெரியுது, மற்றபடி நல்லா இருக்கான். That's the sort of complaint they say. They don't have any other issues. Poor vision in one eye leads to exotropia. In a grown-up children, the eye drifts toward exotropia. If it's a younger children with a strong convergence mechanism, they go for a sensory esotropia. Consecutive, I just said, as a surgeon, if you overcorrect esotropia, you may induce the exotropia. The same thing can happen. You overcorrect an exotropia, you can induce the esotropia. So paratic strabismus, third no palsy would all evaluated in your medicine posting, would have been referred to the eye department for your ophthalmic evaluation. Of myasthenia, be on the lookout, drooping of lid with the ocular motility problem. Always think of myasthenia myopathy as a differential diagnosis. Restrictive strabismus, a lot of systemic problems have ocular motility components. So thyroid orbitopathy, parasitic cysts in the orbit can have ocular motility restrictions. So peculiar restrictions. So we do a orbital CT scan or MRI scan, you can pick up a cyst or vascular anomalies, whatnot. Tumors could be primary ocular tumors, or it could be secondaries from elsewhere. And musculofacial anomalies can result in a lot of bizarre eye movements. I don't want to really go much in the deep of it. Again, most of the time they come with eye strain, asthenopia symptoms. So evaluate them, carefully evaluate them for ocular motility problems. Refraction again, then fundus examination. These are the two, three basic things which you always have to look for. And simple refractive correction, and certain areas we do some sort of eye muscular orthoptic eye exercises. They make it all right. And surgical correction is just the opposite. Here we know the lateral rectus muscle is overacting, so we want to weaken it. We recess it. We take it away from the insertion and put it further back. So weaken the muscle action. And middle rectus is resected. It trimmed and inserted to the original insertion to tighten the eye, to pull the eye back to the orthophoric position. And just come to the final slide. Maybe I'll just play the video. Like squint surgeon, we don't do very huge heroic stuff like cataract and glaucoma, but it's all. Most of you would have had an experience of having seeing the ocular muscles during your probably during your anatomy classes. I was impressed once. I remember there was a modules of your Oculofest when there was one person has done a dissection and he was demonstrating the structures and cadaver dissection. And when you go for a retrieval of eyeball, that's a time we can have an idea regarding the ocular muscle structures. So how thin the lateral rectus is, how thick the medial rectus is, superior inferior rectus, and whatever theory you have read about analysis of Zinn, the insertion from, we are not going to measure it, but then we all know they have various insertion sites, 5.5, 5.9, variable insertion. So these things will give us an idea. In squint surgery, what we do is we just little bit displace the muscles. So herein we hook the muscle, clear all the tenons and the attached ligaments, and the suture used is a 6-0 Vicryl. It is an absorbable stitch. There can be a bleeder, and that's not a big issue. Like, and the muscle is disinserted. Only thing we can always say about our innovations in our surgeries, not been going around for a long time, is adjustable sutures. So like putting in a shoelace knot and redoing it the next day, something like that, redoing your tightness, we can go back the next day and you can readjust the alignment. So we can measure and readjust the alignment. Even if it is a kid short day, you can do it. So that way, the achieving a very good we just see the muscle is disinserted. This is a muscle stump, and I'm passing the needle through the original insertion. So the muscle will be hanging loose on these two sutures. You can just imagine it's like a hanging. The muscle is hanging on the two sutures, maybe 5 to 6 millimeters, 7 millimeters from the original insertion. The muscle is weakened and it is let to hang with a sort of a we can make a sort of a loop knot, a slip knot, so that next day you can go ahead, release the slip knot, and you can either pull the muscle. You pull the muscle, you are reducing the correction. You are releasing the muscle falls further back, where the intended correction can be increased. That's the way we titrate our correction. I'm just making so that's it about the surgical part of it. So just wanted to show us small clipping. Thank you, Parthiban. Parthiban? I'm through.
Ramesh, கேக்குதா?
Yeah. One thing, Parthi.
I think mute ஆயிருக்குன்னு நினைக்கிறேன்.
உங்க வாய்ஸ்
மியூட் ஆயிடுடா. யூ ஆர் மியூட்டட். கேக்குதா?
Sir, your voice is audible, sir.
Okay now?
Sir, your voice is audible, sir.
Ramesh sir, better.
Sir, your voice is audible, sir.
Yeah, Ramesh கேக்குதா?
Yeah, fine. Is it okay now?
Sir, super sir.
Jay.
Sir.
ரமேஷ் கேக்குதா?
கேக்குது பார்த்திபன். மூணு டீச்சர்ஸ், 2 கோல்ட் மெடலிஸ்ட். அவங்கள மாட்டி விட்டீங்களா?
என்ன ஃபேமிலி ஆஃப் கோல்ட் மெடலிஸ்டா இருக்கீங்க, எல்லாமே கோல்ட் மெடலா இருக்கீங்க.
நீங்க தான் சார் தனியா தெரிஞ்சீங்கடா.
விஜய் வீடியோல வா விஜய். VRV sir, thank you so much sir. Thank you so much sir for being a part of this. Thank you so much sir. Really honored to have you sir.
Thank you very much.
Sir, thank you sir. Thank you for being a part. Vijay, thank you so much.
Vijay silent.
அந்த வந்து சார் இருக்கு சார்.
அவர் பையன் வந்துட்டான். அவர் பையன் வந்துட்டான்.
பையன் படமா இருக்கு.
ரமேஷ்
சொல்லுங்க விஜய், சொல்லுங்க பார்த்திபன்.
நீ பிரசனா இந்த பக்கம் தள்ளி விடு ரமேஷ். என்ன ரமேஷ் அகாடமிக்ஸ்க்கு தள்ளி விடு. பையனுங்க எல்லாம் பசங்க நல்லா பெனிஃபிட் பண்ணுவானுங்கல்ல.
கட்டாயம்
அப்பாவோட உட்கார்ந்துருக்காத சுத்தி, நீ இந்த பக்கம் வந்துரு சுத்தி.
இல்ல அதான் சொன்னேன், இன்னைக்கு மீட்டிங்கே என்னை வந்து கௌத்துற மாதிரி மீட்டிங் மாதிரி தோணுச்சு. 3 டீச்சர்ஸ், 2 கோல்ட் மெடலிஸ்ட். இங்க நான் என்ன பண்ணேன் எனக்கே புரியல.
இல்ல I'll be honored. VRV sir எல்லாம் கூட இருக்கிறது வந்து it's a huge inspiration for all of us. Sir has always been a part of Oculofest. எல்லாம் உண்மையிலே we are all very much this thing.
Actually இன்னைக்கு காலையில பார்த்திபன், நான் டாக்டர் மீனா we just discussing the Oculofest initiate பண்ண ஒரு டைம். அப்போ immediately she said this one thing that was very much appealing was like அப்ப நீங்க விஜய் நல்ல ஒரு டீச்சிங் யங் HODs, அந்த ஸ்டூடண்ட்ஸ்க்கு வந்து அண்டர் கிராஜுவேட் லெவல்ல you are able to give them so much of momentum.
யங் இல்ல ரமேஷ், எங்க நானே டீன் பேனல்ல உட்கார்ந்திருக்கேன், நீ போய் டீச்சிங்.
பை ஹார்ட் சார், பை ஹார்ட்.
விஜயரான் சார் கம்பேர் பண்ண நீங்களே யங் தானே?
That is always young at heart. எப்பவுமே சார் எங்களுக்காக always young at heart. அதான் நான் சொல்ல இன்னும் பெருமையா இருக்கு சார் வந்து எங்களை வாடா போடான்னு கூப்பிடுறது வந்து உண்மையே we feel really honored. Only very few people can really relate to students. அதுல sir is one among them. உண்மையிலே
I still remember ஆடிட்டோரியத்துல நின்னுட்டு உங்களையும் விஜயும் சார் என்னடா கரெக்ட் தானடா அப்படின்னு அந்த கரெக்டர் தோணில அப்படியே ஒரு கிளாஸ் எடுக்கும்போது அந்த ஒரு we really miss that. I think still
as I was telling my students like VRV sir on stage is something should be really cherished. So online la pesadhoda VRV sir எல்லாம் on stage பேசுறது இன்னும் more attractive and really very very interactive also. பசங்க எல்லாம் கூப்பிட்டு front row ல உட்கார்ந்து கேள்வி
ரஷ்யன் சர்க்கஸ் மாதிரி இருக்கும் சார்.
sometimes நானே சேர் கடியில போயிடுவேன், எங்கடா நம்ம ஸ்டூடண்ட்ஸ் முன்னாடி மானத்தை வாங்கிடுவாருன்னு சொல்லிட்டு பயந்து. Actually it's great, very very very
பார்த்தி நல்லா ஞாபகம் இருக்கு. விஜய் இருக்காப்ல, விஜய் போஸ்.
ஆமா ஆமா.
அவங்க அப்பா ஒரு 5 years பேக் அவர் கிளினிக்ல எவ்ரி டே ஜெனரல் ரவுண்ட்ஸ் வைப்பாரு. ஒரு அகேஷன் மதுரைக்கு போனப்ப ஐல உனக்கு சில क्वेश्चन வச்சிருக்காரு, மீட்டிங் வந்துடுறாப்ல. ஈவினிங் அப்படி பம்மி ஓடியே போயிட்டது கவர்மெண்ட் அது மாதிரி. இல்ல மேபி விஜயரான் சார் and all would have had so many years of seeing so many of the students coming out through him. So what probably he all dreamt, Vijay and Parthiban Vijay ningala pandringa. So UGs ku PGs ku really a very good momentum. So that is what made us also regularly every year involved in this sort of program to give us a lot of happiness.
Thank you Ramesh. Thank you sir.
Sir இந்த வாட்டி எல்லாமே ஆன்லைன்ல பண்ணியாச்சு சார். மத்தியான பிரியாணியும் ஆன்லைன்ல அனுப்பிச்சு விட்டீங்கன்னா எல்லாரும் சோறே போடலையா சார்?
படத்தை மட்டும் காமிச்சிட்டு விரல நக்கிக்க வேண்டியதுதான். This is the 10th year actually of Oculofest. 10th year running live the same continuously we've been doing it for this the 10th consecutive Oculofest that we've been doing.
Okay.
So with all your best wishes, your contributions, thank you so much for being a part of this program. My sincere thanks to VRB sir, my teacher, Vijay, my good friend, Ramesh, my good friend, and great this thing, Prasanna, the greatest, Shruti, the greatest ever.
Thank you.
Parthi, PGs ke edavadhu chinna oru journal club something organize pannanga.
I think it's a trend setter. I think we should really interact more. Idu mari vechittu I think
நீங்க எங்க இருக்கீங்க? அவர் மதுரையில இருக்காரு. அந்த PGs group மட்டும் ஏதாவது பண்ணலாம்.
நாங்க டெய்லி பண்ணிட்டு தான் சார் இருக்கோம்.
அப்ப ஏதாவது நாங்களே ஜாயின்
டெய்லி
Ramesh, we are doing actually every week we are doing actually பண்ணிட்டு இருக்கோம். But Vijay is also doing actively.
Okay.
Vijay எல்லாம் சும்மா விட மாட்டாங்க. பெண்ட் நிமித்திடுவாங்க ஸ்டூடண்ட்ஸ்.
நான் ஒரு தடவை போயிருக்கேன் மதுரைக்கு.
We'll call you as one of the speakers இல்ல. வாங்க, we'll participate also இல்ல. Really.
Okay.
பசங்க ஏதாவது சொல்லணுமா சார்? பசங்க ஏதாவது சொல்லணுமா? அவங்களுக்கு ஏதாவது அவங்க பக்கத்துல இருந்து
பசங்க யாராவது டாக் யாராவது ராஜேஸ்வர் பேசுறியா? ராஜேஸ்வர், ஹரியரன், your this thing thoughts on the thing.
Yes sir.
Rajeshwar,
sir, that was a very useful session, sir. From start
video போடு ராஜேஸ்வர்.
மூஞ்ச காமி.
சார் பொண்ணெல்லாம் இல்லடா குடுக்கிறதுக்கு, பரவாயில்ல காமி.
sir, 1 second sir. sir
யாரும் பாத்துக்கலாம்ல
சார். இவன் நல்லா பேக்ஸ், நல்ல அனிமேஷன்ஸ் வீடியோஸ் எல்லாம் நல்லா பண்ணுவான் சார். வெரி டேலண்டட் கை ராஜேஸ்வர். அவங்க பேட்ச் ரெப்.
ஓகே ஓகே, அவர் நம்பர் அனுப்பிச்சு விட சொல்லுங்க. ராஜேஸ்வர் செல் நம்பர் சொல்லு. செல் நம்பர்
sir 6381 364 225.
ராஜேஸ்வர்.
Yes sir.
Yeah, Hariharan va come on to sing video la va. Hariharan, Samir va. Yeah, Hariharan, Samir, Indu, Tarni ella va. Your thoughts on this thing program? We thank the teachers for this thing, man. Thank you to sing. Orota pace. Hariharan, your thoughts?
Thank you sir. Thank you so much. It was very useful.
Volume. Increase your volume. Come closer and talk.
Hello sir.
கேக்குது சொல்ல. ஆனா ரொம்ப கம்மியா இருக்கு.
Come closer and talk.
அதென்ன J44 னா
பண்றது.
Tarni வர சொல்லு. Tarni west. Rajeshwar call Tarni to ask her to talk.
ராஜேஸ்வர்.
தாரணி. Sir Tarni, நீ சொல்லு.
தாரணியா தாரணியா?
Yes sir, Dharani sir. Actually, thank you so much sir. It was very wonderful and the session was interesting. The topics chosen was extremely interesting. It wasn't like completely theory based, and since it was practical based, we felt interested to know more about it sir.
சரி தாரணி, உன் மூஞ்சே காமி.
Sunday இப்படி பயமுறுத்த கூடாது. நீங்க சண்டேல எல்லாம் you should not see.
ஏய் தாரணி ஹரிஹரன் வந்துட்டாங்க.
தாரணி ஓகே, அவ நல்லா பேசுவா சார். she talks well.
தாரணி மூஞ்சி போயிடுச்சு.
Yes sir, I have it once.
ஓகேடா ஓகே. வெரி குட். என்ன மின்னல் மாதிரி வராங்க. டேய் மின்னல் அந்த டயலாக் தெரியல. வாமா மின்னல் நான் டக்குன்னு முடிச்சு தாரணி ஓட்டி வந்துட்டு போயிட்டா. வாமா மின்னல்.
Hey Rajeshwar, thank you so much for coordinating. Okay.
Thank you sir.
Sir, on behalf of Oculofest team, my students, KP, Alarme, thanks everyone. Thank you so much. Thank you so much. Thank you, Prasanna and Shruti. Thank you. Thanks a lot.
Thank you so
Thank you so much, sir. Thank you, sir.